for all the valvular conditions. Starting with the easy one. Aortic stenosis. Tell me what you guys know about it. Which age group? What murmur? And what are the signs? Age. Okay. Murmur. And signs and symptoms. And treatment. Go ahead.
And older patients, or calcification in older patients.
Very good. Older age group. Always. Aortic stenosis always in the older age group. Then if it is, for example, if I say there is somebody who is 45 years old and has aortic stenosis, what can be the cause?
Bicuspid aortic valve.
Very good. Super. Bicuspid aortic, congenital bicuspid aortic valve. Two causes. Okay. High yield, two causes. Older age group and bicuspid aortic valve. What murmur do you hear in aortic stenosis?
Ejection systolic murmur.
Very good. So again, it's just a matter of imagination. This is the heart, left atrium, left ventricle. This is the aorta. Now, if this is stenos, so blood trying to go out when the ventricles are contracting. So during the systolic phase, blood trying to rush out of the stenosed valve, and that is going to make noise, right? That is why there is early peaking systolic murmur, systolic ejection murmur. Oh, here. Then what are the signs and symptoms?
Syncope.
Syncope, very good, of course. Syncope, because again, aorta blockage, so nothing going up. So most commonly syncope, then dyspnea, breathing difficulties. There's angina, there can be heart pain, eventually heart failure, signs and symptoms can be there. So all those things, classic dyspnea and everything. Treatment, what is the treatment?
Valve replacement.
Sorry, treatment is?
Valve replacement.
Very good, valve replacement, always valve replacement. Guys, just a second. फोन पर बात करने से तो भूल जाए का तो समझाए
ओके ओके हाँ कई बात नहीं तुम टेंशन नहीं लो हम काम कर लेंगे
प्लस आईडी
हां तुम्हारा के तो चलेंगे मैसेज भेज हां ओके તમે કેમ પણ એમની પાસે પાછા જો બાપુ જરે કેઈ છે કે નથી મજા હા તે ડીએલ પટેલ ના માર્મિક ભાઈ તો હું વાત કરી લઉં છું ઓકે ખબર ન તો હમણાં બધાને મેસેજ કરી હા ચાલો જય શ્રી કૃષ્ણ હા
Hello. Hello. Yeah, sorry guys for the break and disturbances today. Okay. So you said valve replacement, right? There is a criteria for it. So when do you qualify, like when does the patient qualify for severe aortic stenosis criteria? What are the classic signs? Two things that we check and say that it is severe AS. Any idea?
Was it less than 1 centimeter cube of area or something?
Yes, valve area usually less than equal to 1 centimeter square. It's not mandatory though. Okay, it is not like compulsory to have this thing. Not mandatory, but yeah, it is one of the criteria. Then,
if it's symptomatic,
no. So see, there are two headings. One is severe aortic stenosis criteria, and other is indications for valve replacement. So what you are saying that signs and symptoms, that is indication for valve replacement. Okay.
Oh, I see.
Severe aortic stenosis has two important things. One is aortic jet velocity. How much? Any clue? Aortic jet velocity
No.
more than equal to 4 meter per second. Okay. So that is
Okay.
aortic jet velocity. And other thing is mean transvalvular pressure gradient. That is 40. So it's easy. Just remember the 4 value. Okay. Aortic jet velocity 4 and transvalvular pressure between the two the above part and the below part of the valve is more than 40 mm Hg. Okay. So this or this should be must be present to call it severe aortic stenosis. This is not mandatory. It is one of the criteria, but this or this has to be there. Clear,
Yes.
guys? Okay. Then coming to indications for valve replacement. So indication is it has to be severe aortic stenosis. Criteria means either this or this plus one or more than one of the following. In that, what you mentioned, number one thing is onset of signs and symptoms, which is angina, syncope. Anything else, you know? There are 3 points. Hmm? Anyone?
The ejection fraction less than like 50.
Very good. Superb. Left ventricular ejection fraction less than 50. And last thing is, if you are opening the patient for something else, like if the patient is going to have any cardiac surgery like cabbage or anything, then might as well just repair the aortic valve. Okay. So undergoing any cardiac surgery. So these are the criteria for aortic valve replacement. There has to be severe aortic stenosis, plus there has to be signs and symptoms or left ventricular ejection fraction less than 50% or patient undergoing any cardiac surgery. Got it?
Yes.
Yes.
Perfect. All right. Oh,
May I ask something?
yeah.
If they not filling these criteria, we are not doing surgery. How do we manage?
Means that the symptoms are not there. If I mean, if basically if this criteria are not met, you don't do anything. It's not bothering the patient.
Okay, I see.
Okay.
I remember a beta blocker thing, but it is it wrong?
It's not
I
mentioned
don't want
anywhere in
to.
the like it's not mentioned anywhere in the treatment of
Okay.
aortic stenosis, so I would not suggest that. And other thing that I have also noted, any valvular conditions that you see, any valvular conditions, the management is only one thing, that is surgical repair. No
Okay,
amount of
thank you so
drugs
much.
can repair the valve, right? But yeah, like you can start anticoagulation or those kind of things just to just for the prophylaxis, aspirin anticoagulation. But I don't think beta blockers or ccvs or anything like of that resort is going to help.
Okay, thank you so much.
No worries. All right, so valve replacement, that is there. So that is aortic stenosis. Then coming to aortic regurg. Again, what are the causes or risk factors, I would say, of aortic regurgitation? What is the clinical features, treatment? Any idea, girls? What are the common causes of aortic regurg?
Like infective endocarditis or rheumatic fever.
Very good, super. So post-inflammatory, whether it is rheumatic fever or infective endocarditis, high yield. Then
Aortic dissection.
very good. Anything that is going to dilate the aortic root. So aortic dissection. or other causes that can dilate the aortic root are Marfan syndrome, syphilis, right?
Yes.
Okay, then what else? One more. Congenital bicuspid aortic valve.
Mm.
Okay, so it is going to cause both stenosis also and regurg. Anything can be possible. Now, this congenital bicuspid aortic valve is like so high. When you see the word congenital, you always feel that it is something that should be detected early on in the life, like small teenage, that patient age group. But I've seen questions where they have given 30-year-old, 45-year-old, something like that. So you would never think of aortic. I mean, at least I did not think of it, because I always said that congenital, so it should be caught up till this time. But it can be very silent, never diagnosed, and then 30 or 45-year-old patient coming to you with all these signs and symptoms, and risk factor is asked, and the answer turns out to be congenital bicuspid aortic valve. So always keep in mind, it can be seen in 30, 45, any age group. Okay, even in elderly. All right, then how is the patient presentation? There is a very typical finding, not like finding, position. If that line is given in the question, you know it's aortic regurg. Like how we talk about pericarditis, patient leaning forward, full expiration, that kind of things, you know, feeling better in pericarditis. Anything like that you know about regurg?
Does the murmur get louder when they move forward?
Very good, very good. Okay, I've misplaced some pages, but yeah, I remember this. So yeah, you are right. When the patient leans forward and you ask them to like fully breathe out and press your stethoscope against the diaphragm on the left hand side, at that time you hear this aortic regurg murmur. And always I've seen questions, they like majority times they have mentioned this line: patient leaning forward in full expiration, and your like you apply firm pressure with the on the diaphragm, and at that time you this murmur is audible. What is it? And the answer is aortic regurg.
Mm.
Okay, so that is there. Rheumatic fever, that we already talked. Post-inflammatory high yield treatment is again surgical. If it is bothering, repair. A lot of questions on diagnosis for all the valves, and the answer is simple. What is the diagnostic test?
Uh,
Echo.
Echo. Yeah. Easy thing
mm,
about cardio, echo.
mm.
Okay. What kind of murmur you hear in this one?
The early diastolic murmur.
Very good. Diastolic decrescendo murmur, because it's regurgitation, right? Means after everything is pumped out, the valve is not working, so some of the blood is coming back again in the relaxing phase. So it's a diastolic decrescendo murmur. Clear everything, everybody?
Yes.
Last question. Tell me what happens to left ventricular end diastolic volume in case of aortic regurg? Increase or decrease?
Increase.
It would increase.
It would increase. Why? You're
There's
right.
backflow of blood.
Yeah, backflow of blood.
Very good. What is left ventricular end diastolic volume? End diastole means what? That at the time of complete relaxation, now this left ventricle, once it has pumped out all this blood, now it is relaxing. It is in the diastole phase. Now it is filling back from the left atrium, right? So in this filling process, because there is regurg, some of the blood is coming back again. So the pressure and diastolic volume pressure increases, right? Makes sense.
Yes.
Yes.
So that is also one very important UL question, but clearly it's easy. You guys know it. All right. Then coming to these two are done. Okay, because we are doing this and infective endocarditis is the risk factor. So let's quickly, it's just a one-liner thing I want you to know. Infective endocarditis. I'm not going in details. You know the causative organism? Yes or no? What is the causative organism for infective endocarditis?
The strep mutants and like
Very good. Yeah. Because of what? Risk factor? Dental procedure, right?
yes.
Yeah. So now they are not going to ask you, this is not step one. They don't want you to know that, okay, there is mycotic aneurysm, those Janeway lesions, osseous nodules, Roth spots, all those things, nobody's asking you. But from the question, you should know that they are talking about infective endocarditis. And now the question is, what is the management?
Penicillin.
Very good. Which route? How do you give it?
IV.
Very good. IV aqueous penicillin G is the answer. You give it every 4 to 6 hours or continuous 24 hours infusion. That is for infective endocarditis, penicillin G. But rheumatic fever, if it is given, then what is the treatment? Now, rheumatic also, you know the classic things, migratory, all those arthralgias and myocarditis and everything. The question will be, what is the treatment?
The same.
Okay, what is the route? So that is the differentiating point. One is benzathine penicillin. This is penicillin G. That is not that important. But one is IV. One is IM. Okay. Rheumatic fever is intramuscular. Infective endocarditis is intravenous.
Mm-hmm.
All right.
Yes.
Then one or two questions on the complications of infective endocarditis. But again, it's easy. If there is this valve involved and there is severe infection, then what are the complications? Number one, there can be abscess around that area, which is a UL question. Perivalvular abscess. Easy.
Yes.
Other thing, patient can go in septic shock. Other
Septic
thing,
embolism.
sorry.
Septic pulmonary embolism.
Yes, even that exactly. So now they can throw embolus to each and every part of the body, brain. So there can be neurologic signs and symptoms. There can be brain abscess. There can be acute encephalopathy, pulmonary this thing, renal infarction,
Yeah.
MSK. There can be musculoskeletal abscess. So all kind of abscesses because of this infective endocarditis. All right, that
Yes.
is easy. Okay, so that is there. Then coming to another, yeah.
So, what's the presentation for like perivalvular abscess? Like how to know this like this complication?
Perivalvular abscess. I think the presentation would be very severe. It's just going to be severe sepsis, and then when you do an echo, because this patient has infective endocarditis, so you will do an echo, right? So it will be
Yes.
seen in the echo.
Okay.
Yeah.
Yes.
Okay. Then this is there. Okay. All right. Then we have. There's one more page. Mitral stenosis is remaining, right? Oh, here it is. Here it is. So actually, in the notes, the few of this was not given. I just added it from outside. So then coming to the mitral valve, done with the aortic. What is the most common cause of mitral stenosis?
Rheumatic fever.
Very good, superb. Rheumatic fever. How for aortic stenosis we know old age and bicuspid aortic valve. Mitral stenosis, just have to remember one thing, that is rheumatic fever. How is the classic patient presentation? Mitral stenosis.
There will be AFib.
Very good, superb. AFib. Always remember mitral stenosis with AFib. Then what else? AFib and progressive dyspnea on exertion. Okay, that's again, like, I know it's something common, but very typical of mitral stenosis. All right, now here comes the important questions. So tell me, what will happen to cardiac output? What will happen to PCWP, central venous pressure, and left atrial size? Think and tell me. Arrow question. What will happen to cardiac
Left
output?
atrium
Okay, left atrial size. Go ahead.
increases.
Very good. Then
Her output will decrease.
very good. Okay. Then PCWP.
Increase.
Increase.
Okay. Then central venous pressure.
Central venous pressure means the preload.
Central venous pressure is the preload, and specifically for the right heart.
Okay. Increase.
Okay. Now, can you explain me why you went for these? So, start with cardiac output. Why do you think it is decreased?
Because like there is mitral stenosis, not enough blood to go from the right ventricle, left atrium to the left ventricle.
Very good. Super.
So the cardiac output will decrease.
Mhm.
BCWP, which is the pressure in the like left atrium,
Very
it's
good.
increased.
Mhm.
And CVB increased because of the like backup of the blood to the right heart.
Superb. Superb. Exactly. Very good.
Mm.
So always imagine simple scenario. Keep it simple. Heart, left atrium, left ventricle. Here there is stenosis, so there is difficulty for the blood to come down. So nothing to
Mhm.
push forward. So cardiac output low, heart is tired. Second thing, backflow in here only the pressure increases because nothing going down. So the left atria becomes dilated. That backflow pressure is going to increase the PCWP. All right. PCWP is nothing but the marker of the pressure in the left atrium, and that backflow going to the lungs, coming back to the right heart, increasing the central venous pressure. Clear?
Yes. Mm.
Right. Class.
It's clear.
All right. Oh, where is Dania? She's not there in the call?
No.
Okay. No worries. I'll send her the recording. Can you guys still see the screen?
Yeah.
Yeah.
Yes.
That's good. Because anytime a call interrupts, so I think the screen just goes away. Okay. Then tell me about these arrows. What will happen again in mitral stenosis only? Pulmonic artery systolic pressure, pulmonic artery, okay. Pulmonary artery diastolic pressure, left ventricular end diastolic pressure.
So the pulmonary artery systolic pressure will increase,
Hmm.
and the
Okay.
diastolic pressure will increase as well.
Okay.
And the left ventricle and diastolic pressure will decrease.
Very good. Super. Why this is increasing?
Like again, like the backup of blood.
Yeah, very good. So of course there is backup, backflow, back pressure. That is one theory. Another theory is there are two factors. Another is that mitral stenosis triggers endothelin mediated pulmonary artery vasoconstriction. So it just triggers this vasoconstriction by releasing some endothelin mediators, and that is one theory. But nobody's going to ask you in detail. That is just for our knowledge. Backflow, so increased pressure, and some mediators that causes vasoconstriction constriction are also released from stenosis. And of course nothing going in the left heart, so eventually it is going to decrease, and left ventricular and diastolic pressure is decreased.
Okay.
Clear?
Yes.
What is a murmur? What is a murmur?
Diastolic murmur.
Yeah, very good. There is a early diastolic sound opening snap followed by a rumbling diastolic murmur because again this is the phase filling phase and there is stenosis, so it takes time to come down while the this is filling, so it is happening in the diastolic phase and there is an opening snap when the blood just first initially gushes down. There is an opening snap, right? Clear up till now?
Yes.
It's clear.
Yes.
Okay. Another important murmur is mitral regurgitation. Now, the classic one that we have known since step one, there is, like, according to us, there is just one basic mitral regurgitation murmur. But in step two, we came to know that it is actually acute, compensated, and decompensated.
Mm.
The acute is a classic MR that we have been doing since step one. Compensated, decompensated is little one step above. Sorry, my pencil is giving me tough time. All right, so let's divide it on these parameters: preload, afterload, contractile function, ejection fraction, and forward stroke volume. You have acute, compensated, decompensated. Main questions are on the difference between acute and compensated. Uh, Difference between these two is not that significant. Okay. All right. So tell me, think and tell me. It's easy only. What do you think? How would be the preload in case of acute mitral regurgitation?
Increase.
Preload is going to be very, very high, right? Because severe regurgitation is happening in the initial phase. In compensated also it's going to be high. Decompensated also it's high because the problem is mitral regurgitation. Stop me anywhere you don't understand. Okay. Then afterload.
Decrease.
Afterload is going to decrease. Okay. Then, but again, the afterload eventually is going to increase because even the heart is tired of pumping the blood out. Okay. So decompensated is the phase where even the heart is completely lost it. Okay.
Yeah.
Not getting it. What happened?
Getting it.
Yes.
Okay. Okay. Then contractile function.
In
The
acute, it would be preserved.
Okay.
the same.
And in compensated or decompensated?
Compensated, it would be preserved. Decompensated, it would be decreased.
Okay, perfect. So contractile function, this is actually the key part where here there is no change because right now it is in the acute stage. So there is lack of time to adapt, right? The heart has still not adapted to the changes. So the contractile function is still the same. Majority of the compensated heart is going to be no change, no change, no change, no change. Main difference is acute versus decompensated. So decompensated means his heart is worn out, it's tired. So here the contractile function is decreased, significantly decreased, heart not pumping. Okay, then what about the ejection fraction?
Acute would be normal,
Okay, then
and decompensated decrease.
okay. So another trick part, ejection fraction is very, very high over here. Why? Remember, ejection fraction formula is like the basic thing is what? Ejection fraction is total stroke volume. Whatever is going forward plus whatever is going backward. Ejection fraction is basically nothing but stroke volume.
Mm.
Okay. Stroke volume means what? Blood going out. Now they don't care whether it is going out this way or because of regurgitation it is coming up this way. The force is very high, so the blood is going to be moving in any direction. That is ejection fraction. The heart is pumping, the contractile function is still the same, so it is going to pump blood forward also and backward also. Make sense?
Yes.
Makes sense.
That is why ejection fraction is not no change or decreased, it is increased. Whereas in decompensated, again, the heart is worn out, contractile function is gone, so ejection fraction is also decreased. And last factor is forward stroke volume. Forward stroke volume. So forward stroke volume, you can say it is decreased because it is regurgitation, so majority is coming back. Um,
Yes.
so forward stroke volume, when the word forward is given, then it is decreased. Ejection fraction is stroke volume, which is backward plus forward, any direction flow. Got it?
Can you repeat the ejection fraction in the acute phase?
Yes, yes. Okay. So basic ejection fraction, as the word suggests, blood that is getting ejected out, right?
Yeah.
Getting it? Now this is the left ventricle. Here there is this mitral valve and there is regurgitation. And this is the aorta. Okay. So left ventricle, when it is contracting, it is ejecting the blood out. That is equal. The contractility of the heart is nothing but an indication of the ejection fraction, right? Means it is ejecting good fraction of blood out. Now here in acute phase, it is increased because the ejection fraction is maintained. Though some is going back here, some is going out, but ejection fraction, blood is getting ejected out of this chamber,
Yeah.
right?
Yeah.
So that is why ejection fraction is increased, which is equal to stroke volume. And stroke
Okay.
volume is the flow, whether it is going backward or forward, that does not matter. Blood leaving this chamber is what counts. That is the heart able to pump the blood out or not. So yes, heart is able to pump the blood out. It's just that because of the MR, it is going in the backward direction. But
Yeah.
the
Okay.
ejection fraction of the heart is well. Getting
Yeah.
it?
Yeah. Thank you.
Okay, perfect. So that is oh, so that is about mitral regurgitation. Now this is the point, like, look at these questions carefully. Mitral regurgitation, I used to get it wrong all the time because I used to forget that there is something called acute and decompensated. So always pay attention, okay, whether it's a new case or old case, and based on these findings, differentiate whether it's acute or decompensated. Then you have, okay, then there is something called pulmonic stenosis and tricuspid, pulmonic regurg. Now we have never seen questions on, I mean, never seen or done it in step one, right? Pulmonic valve involvement. So pulmonic stenosis is very rare. It's a very rare condition. Can you tell me what can be the cause of pulmonic stenosis?
Congenital.
Very good, congenital. Okay, and just like bicuspid aortic valve, this patient presentation is also in 30s or 40s. Pulmonic stenosis, most common cause is congenital, and it is very small, so it can be most commonly it presents later in life. Okay, how would be the murmur?
Systolic murmur increase with inspiration.
Super, very good. So always this is a high yield point. Whenever this word is given in the question, increased with inspiration, it's very easy. Rule out all the options that are from the left heart. Rule out aorta, rule out mitral. Okay. Increased with inspiration is a classic finding for right heart valvular conditions. Okay. Increased with inspiration. Why? Why do you think it increases with inspiration? Any right heart problem? Why? Do you know the logic?
The pressure in lungs increases, so it would be
Hmm?
harder to pass the blood ahead.
Increase the preload.
Increase in preload, yes. So whenever there is inspiration, means all the blood is coming back to the heart, right? Because it has to go to the lungs to exchange that O2 and CO2. Okay. So whenever there is inspiration, there is The entire venous return is right now coming back to the heart. And you know that whenever there is increased preload, the heart is full, all these murmurs are going to increase in intensity. Make sense?
Yes.
So whenever there is increased with inspiration, the right heart murmurs are going to increase in intensity. There's just one question on this pulmonary stenosis. So that is this increase in intensity. And then there is one question on pulmonary regurgitation, another very rare condition. Can you think of any cause which would cause pulmonary regurgitation?
Carcinoid syndrome.
Oh my God. Okay. Long shot. Yeah. Carcinoid had some pulmonary right heart issue, but it wasn't causing
Mm.
this. But yeah, it is associated with carcinoid. But what is the cause of pulmonary regurgitation?
Any radiation?
No, actually, it's very tough. You know what? It's actually very tough. There's just one most like it's seen. It's a rare condition. It's never seen only, but it can be seen if the patient had tetralogy of Fallot.
Mm.
Now, if the patient had tetralogy of Fallot in childhood, means the patient had pulmonary stenosis in childhood, and pulmonary stenosis must have been corrected. So, correction of pulmonary stenosis. You know that
Okay.
whenever there is valve repair, there is a good chance that there can be failure of that surgery because that valve can eventually start regurgitating, getting detached, infection, all those things, right? So correction of pulmonary stenosis is a risk factor for pulmonary regurgitation. And there was a UL question where they gave that childhood the patient had TOF. Now, if you don't know that there is something called pulmonary regurgitation, you might get it wrong.
Okay.
Yeah.
Yes.
So, in short, patient with pulmonary stenosis, remote or past or anywhere, and was corrected, there is a risk of regurgitation from that valve. Whew. Oh, oh, oh. Ah. Okay, so this valvular conditions are over. Thank God. Both the ventricles contracting. So major P wave is the atria contracting, major QRS is the ventricle contracting, right? And then ventricle relaxing is the standard T wave. Got it? So again, this is
Yeah.
no activity. P wave is the atrium contracting. PR interval is the signals from the AV node reaching to the septum. Then the dip is that. Then the QRS, which is the main thing, which is the ventricle contracting, and then the T wave, which is ventricles relaxing. Clear?
It's
Yeah.
clear.
Everybody clear up till now, right? Okay.
Yes.
Now about this ECG, you don't have to remember everything. We just need to know this thing that there is one big block and then there are small blocks in it. So the small blocks are 1, 2, 3, 4, and 5, and 1, 2, 3, 4, and 5. So total this one teeny tiny is 0.04 second, and into 5 times means the entire block is 0.20 seconds. Okay, just remember this value for one situation, or remember this thing that there has to be 5 tiny blocks to complete one block. I'll tell you where to implement that, but you guys just have to remember this one big block, it has small tiny blocks, and yeah, that's it. All right, so why do you need to know that? Let me show it somewhere. Okay, just remember that, keep it on standby. Then there is one more thing that we need to remember between each this R interval. Okay, the big R's. Approximately, again, you don't have to count everything. Just look at the bigger blocks. Approximately, there has to be 3.5 to 4 blocks, which is normal. Now, all these mathematicians have done the job. We don't have to do all that calculation, and plus, I'm very bad at it. So just remember that this normal in between 3.5 blocks is our normal ideal pulse rate, which is around 75. Now, if you this gap decreases, means this RR becomes this much, means that it is coming close, the heart rate is increasing, it is becoming tachycardic. So according to the calculations, it gets adding 20, 25, 50 or whatever. So it starts becoming 100, 150 and 300. If you prolong it, if the distance increases, it starts becoming slower, bradycardia, right? So 60, 50, 40 like that. But again, no use of the values, just have to remember the number of blocks. Between two major RR interval, there should be 3.5 to like 4 blocks, which is normal. If the blocks are more, you know it is bradycardia. If the blocks are less, you know it is tachycardia. Nobody is going to ask you the exact value. Clear?
Yeah.
Everybody?
Yes.
Yes.
Now, one last concept, and then you guys will be solving the ECGs for me. And that concept is, whenever there are going to be a lot of ECGs in step 2, at least like I had it, not, I don't know if others are having it or not, but we both had a lot of ECGs in our exam. Now, I don't want to scare you. The good thing is that even if you don't know ECGs, you don't like them, the literature that they give in the question actually is very informative. That will help you solve the question easily, even if you don't know how to read the ECG. Okay, they have enough information in the question, and directly you can solve the answer from that. But it's easier to read the ECG with these 4 rules. Number 1, whenever you see an ECG, check P wave. The first thing, check the P wave, whether it is there or not, present or absent. Second thing, check the QRS, whether it's normal or wide. Normal is, these are 5 blocks that we talk about. Normal is this 1 block. QRS is 1 block. Okay. So if it is more than 1 tiny block, means it is wide. Narrower than 1 tiny block means it is narrow. Got it? Guys?
Yes.
Yeah.
Yes.
Okay.
Yeah.
So first thing is, my bad. Okay, but anyways, yeah. First, check the P wave. That is actually, I messed up. We have to check P and QRS, but that is third and fourth. First was to check the rate and rhythm, which I completely forgot. Okay, so first is to check the rate, whether it is regular, irregular. All these RR intervals are coming at the same distance, 3 blocks or not. Okay, and second is the rhythm. How is the morphology? How is the rhythm of the ECG? Okay, so 4 things you have to check. First, whether the rate is in the normal range, whether it's brady or tachy. Rhythm is regular or irregular. P wave and QRS is normal or wide. Got it?
Yeah.
Okay.
Okay. Now, don't mug it up, but start doing it from here. You'll solve a few and then you'll get the trick. So, first things I told you, check the rate.
Rate is normal.
Because there are how many blocks? 1. Everybody can see the screen, right?
Mm,
Yes.
One big block,
yes.
2 big block, 3, and almost like 4, 3.5 to 4.
Mm,
Right? Everywhere. 1, 2, 3, 3.5. 1, 2, 3, 3.5. So the rate is regular, 75 around heart rate.
mm,
Right?
mm.
So that is done. How is the rhythm? 3.5, 3.5, 3.5, 3.5, 3.5. So it is regular, right?
Yes.
Yeah.
Then check the P wave. Is it present or not? This is a
Yeah.
P wave. This is a P wave. P, everywhere P wave. So yeah, P wave is present. Then I'll check the QRS. QRS, yeah, like 1.5 2 tiny blocks. 1.5 2, 1.5 2, 1.5, 1.5. So QRS is also present and normal. Okay.
Yes.
Yeah.
So this is a normal sinus rhythm.
Mm-hmm.
Understanding it?
Yes.
Yeah.
Just check the 4 things. Got it, right? Any doubts so far?
No.
All right. Now, this also you have to remember, which I forgot to mention earlier, that the distance between the PR interval, basically, this PR interval should be one block. One block. It should be always less than 0.20, which was basically one whole block. I told you one tiny block is 0.4 and
Mm.
5 of them, so total would be 0.20.
Yes.
That's a big block, right? So
Mm-hmm.
PR interval, the distance from the P wave starting point to this div, this should be 0.20, means one block, big block. Got it?
Yeah.
Yes.
Yeah. So what is the one condition where the PR interval is prolonged?
Mm.
Heart block.
Very good.
First degree
First
heart block.
degree AV block, like of course second and third degree also, but the main problem in first degree AV block is the PR prolongation. That also will come across. But yeah, these are the few things that we have to check. Come on, now you guys tell me this one. What is it? The four things. Go with the four things.
Rate is bradycardic.
Very good, because there are one, two, three, four. So okay, more than four, five, six, seven, 7.5. Right? So rate is Brady. Then oh sorry, rhythm is Brady. Oh no, rate is Brady. Sorry. I get confused often in this. Yeah, rate is Brady. Rhythm is
Regular.
Yeah, regular.
regular. Okay, very good. Rate, rhythm, P, and QRS. What do you think? Is there a P wave?
Yes.
Yeah.
Yeah.
You all can see the P wave, right? QRS,
Yes. Yes.
Yes.
Normal.
normal, right? So it's a sinus bradycardia.
Mm-hmm.
Got it?
Okay.
Yeah.
Everyone following, right?
Yes.
Mm-hmm.
Yes.
Okay. Oh, sorry. You guys already read it. But anyways, tell me what is this? Rate, rhythm, quickly, quickly, now, quickly.
So the rate is tachycardia because there's 2.5, two large
And I have
blocks.
Yes,
two
very
large
good.
blocks probably.
Rhythm is
The rhythm is normal,
Very
yes.
good.
regular.
P wave is
P
present.
wave is present.
QRS is normal.
Perfect.
There is
Right? So this is sinus
Tach-
tachycardia.
tachycardia.
All right. Now, what is this?
Okay, so
Little tough on this one is, but it's okay. Start with the rate, rhythm, and PQRS.
So the rate
rate is Brady, I
is
guess.
yes.
Yeah, it's around 100.
Rhythm is regular.
Little
Rhythm,
slow. Then
rhythm is irregular.
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 you're saying
Yeah.
rhythm is irregular?
Mm-hmm.
Yeah,
Irregular.
because there is one beat
Yeah.
over here. Okay. But otherwise, rhythm is fine. There is just problem with one beat, right?
Yeah.
Okay.
Okay.
Yeah.
Then
P wave is present.
P wave is present. Okay.
QRS is
QRS.
also present.
No, no. Okay. So I'll
Mm.
tell you what this is. This ECG is premature atrial contraction, I think. Yeah, premature atrial contraction. Because why? The entire ECG is fine. There was a P wave, QRS is there, T wave is there. But suddenly, after that T wave, quickly there is another heartbeat following. The P wave, QRS, and T wave complexion is following, right? So it just means that whenever there are one or two such beats, this ECG just has one beat, but one or two such beats where each and every component is present. The P, Q, R, S, T is present, but it is just beating ahead of its time, and like the P wave is shifting ahead. That is called premature atrial contraction. Okay. Because this P wave means the atria contracted ahead of its time, did not give the time for the ventricles to completely relax, and quickly the atrial contraction started. That is why you have the entire beat shifted ahead. Okay, just one beat. Got it?
Yes.
Yes.
So that is premature atrial contraction. Another peculiar thing about this one is that the morphology of the P wave usually is actually unusual. It's bizarre. Whenever you have premature here, they have not given it in a weird way, but theoretically from you world, it is supposed to be abnormal. Okay, the P wave morphology in premature atrial contraction is abnormal. The shape is abnormal, and there is something called premature ventricular contraction. So ventricular contraction means again the QRS is earlier ahead of its time. So in that also the QRS morphology would be abnormal. Got it? But the entire ECG would be normal. All right. Then what is this? Oh, what is this? Yeah. There are two actually, but
Rate is tachy.
rate is tachy.
Rhythm is irregular.
Rhythm is irregular, absence of P wave.
Very good.
Yeah.
QRS is normal.
QRS
So what
is
do you think this
normal.
is?
It's AFib.
AFib.
Very good. This is AFib, right? Only condition where you know that the P wave is absent, rate is irregular, right? Everybody following, right?
Yeah.
Yeah.
Behram, can you hear me? I just want to know if he's there or not. Is he there? Can you can you see the name?
Yeah.
Okay. Behram, are you feeling shy?
Yes, I can hear.
Oh, you can hear me. Great. Yeah. Because I like to hear everybody's voice. I want to know that everybody's alive and paying attention, not sleeping. So, are you at some place where you cannot speak? Then I won't ask you questions. It's just like I don't want to feel ghosted.
Sure.
You can answer me. Hello. If you're saying something, I cannot hear anything. Okay. I'm considering that maybe you are at a place where you cannot speak, right? Okay. All right. Let's go ahead with. All right. Tell me what is this?
Rate
Every-
is
Rate is
bradycardic.
bradycardia.
Hmm.
Regular.
Okay. Regular.
Regular and
Is P wave present?
Hmm. Yeah, because there is
Yeah.
this.
there is
Yeah.
P waves.
Yeah.
QRS
There's no.
is
Wide.
normal.
Yeah.
Yes. Okay. But what is this pattern? This is a typical pattern for something.
This is atrial
Atrial
flutter.
flutter.
Yeah.
Yes.
Delta wave.
It's the classic sawtooth pattern,
So
right?
appearance, yes.
Yeah.
It's atrial
Yeah.
flutter.
Mm,
Okay.
mm.
Sawtooth pattern. Yeah. Okay. What is this? Very important. What is this? Okay, let's start with rate, rhythm. Tell me quickly. Rate, rhythm, please.
Rate tachycardic.
Tachycardic.
Okay.
Rhythm
Regular.
regular.
Very good.
Rhythm is
Regular.
regular.
P wave is
Absent.
Absent.
Okay.
QRS is present.
QRS is present. P
mm,
wave is
Yeah.
questionable. So what is this?
supraventricular.
Supraventricular tachy.
Very,
Yes.
very good. So always remember that when there are two situations where the P wave can be absent or not seen. Number one, where it is absent is flutter. And how do you differentiate fibrillation with supraventricular tachycardia? In fibrillation, the rate, the rhythm is irregular, right? Here, the rhythm is regular, same interval. Plus, there is super like tachycardia. And second thing, the P wave is actually present over here, but it is just hidden under the T wave. Okay. In reality, it is present. You can see a little notch everywhere. But anyways, it's usually on the ECG. It is hidden under this T wave. Why? Because this heart is contracting at such a huge speed, like such a fast speed, one and like literally what, one block, so 1.5 blocks, so around 250, 300 it is beating that fast. So what happens is that P wave contraction, the atrial contraction is happening, but you cannot see it. Okay, there is an overriding T wave under which the atrial contraction which is actually happening is just getting hidden. Getting it?
Yes.
All right, so that is supraventricular tachycardia. We'll talk about the management and everything in details, but you guys are getting the ECGs, right?
Mm-hmm.
Yeah.
Yes.
Okay. Then what is this? Rate, rhythm, come on.
Rate
Hmm.
body.
Okay.
Irregular rate.
Hmm.
Rhythm is
Okay.
also irregular.
Okay.
P wave is
P
present.
wave is present.
Very good.
The QRS is prolonged.
Is wide.
White, yes.
It's wide.
All the QRS are wide or one is wide?
One is wide.
One
Wide.
is white.
I told you. So what is this condition?
Mm.
Premature ventricular, maybe.
Very good, very good. Premature ventricular contraction. Whenever only one beat is ahead of its time and the morphology is different than the others, right?
This is what?
Premature ventricular contraction. The ventricle contracting ahead of its time. So one beat is shifting ahead of its time. It was supposed to be over here, right? But it is ahead of its time. Means the ventricles are not waiting and they started contracting. All right?
Yes.
Okay,
Yes.
and one classic feature about both these premature contractions are that their morphology is bizarre, different, weird. Okay, widened or bizarre morphology. Got it, everyone?
Yeah.
Yes.
Yeah.
Yeah.
What is this? Rate regular, rate rhythm things.
Rate tachycardic, regular
Hmm.
rhythm.
Regular
Hmm.
rhythm. P wave is absent.
Hmm. Hmm.
QRS is prolonged.
Very good. What
Long,
is it now?
long QRS.
Ventricular
Yeah.
tachycardia.
Ventricular tachycardia.
Very good. It is ventricular tachycardia. Which type of ventricular tachycardia is it?
Monomorphic.
Maybe monomorphic.
Very
Yeah.
good. Monomorphic. Why? Because each and every this is similar, monomorphic, similar morphology of each and every Q, the waveforms. All right. So this is monomorphic ventricular tachycardia. All right. Perfect. What is this?
Torsades. VFib.
Velocities,
Yeah.
quantities.
Pulses.
Polymorphic.
Polymorphic. Torsades point. It is confusing, but for torsades points looks something like this.
Mm.
Okay.
But here it's not getting, it's still like different morphology than this one, right? It's not that classic DNA
Okay.
wala thing. Okay,
Okay.
so it's polymorphic ventricular tachycardia, different morphology. Ventricular tachycardia. All right, what is this?
Yeah. This VFib, no?
Yes.
Yeah, not making no sense, the ECG making no sense, that is VFib,
Mm.
right? most common cause of death in Most common cause of sudden cardiac death in MI patients, acute MI patients, right? VFib.
Yes.
All right. What is this? You have to again start with that thing for this one. Oh, this is all. This is the this is nothing. This is that pulseless electric activity asystole thing. Forget it. Nobody's going to ask that ECG. Yeah, this is again check all things here. Rate, rhythm, P wave, QRS.
Rate bradycardia.
1, 2, 3, 4. Not Brady, right?
Okay, okay.
Regular.
4 is there.
Regular.
It's for
Regular. Okay.
QRS normal.
P wave is present.
Yes.
Present.
It is
Okay.
present,
PR prolonged.
That's PR
but it's prolonged.
Very good. Superb. Good thing that you notice. So when you think that okay, everything is fine, the next thing you have to check is the two values that we are talking about, the PR distance and the QRS. Like if you think that the patient has some problem, but the ECG is absolutely normal, then try to look for all these values, right? So PR prolongation from the point of starting till the point of this dip, that is the point of this R is the PR prolongation. So I told you it should be not more than this one block. Here you have one block, you actually have two whole blocks, right? Two blocks.
Yeah.
So it is PR prolongation. So what is it?
first heart block.
Very good. First degree heart block.
Mm.
All right.
Mm.
What is this? Rate is okay, same.
Yes.
Rhythm is also regular,
Mhm.
but in between there is a gap.
Mm.
Then
Yeah.
P waves are present.
P waves are present.
QRS is also there. Then what is the problem?
One QRS is missing.
One is missing. Yeah.
Very good. One is missing. What else is the issue? Something else is also problematic.
PR is getting
PR
prolonged.
is prolonged.
Very
Yes.
good. Here it is this much, then bigger, then bigger, then bigger,
Yeah.
and then a drop, right? So what is
Yes.
this?
It's one.
Mobitz type 1,
Mobitz
right?
type
Second
1.
degree heart block type
Right.
1. Got it? Everybody followed?
Yes.
So whenever there is slow, and then getting prolonged, constant PR prolongation and then a beat drop, that is Mobitz type 1. What is this? Again, rate is okay. Rhythm is okay. P
Rhythm is
waves are
regular.
also there.
QRS is
QRS is there. I mean, that's okay
yeah.
only. There's
So
a
this is a
problem here.
constant PR,
Very good.
and this is Mobitz type 2.
Yeah, where there is constant PR. There is no PR prolongation, but there are random QRS drops. Like not just QRS, it's QRS, random QRS drops or random beat drop, right? So when
Right.
there is prolongation of the PR interval and then a beat drop, that is type 1. Random drops is type 2. Okay?
Mm.
Without PR prolongation.
Yeah.
And then last is the type 3. Type 3 is basically where the atria are contracting in their own way, ventricle are contracting in their own way. They have no correlation with each other. Okay, so for example, if this is a P wave, then it is not necessary that the QRS has to follow it. Okay, they can be like anywhere in the timeline. For example, if this is a P wave, the QRS can be here. Basically, not together, not in same continuity, but present in the ECG. That is Mobitz type 3. All right.
Yes.
Okay. Yeah. Ball management. Should I call? Just a second, guys. Should I call him? Pratik, મેસેજ કરું એને મેસેજ કરું શું કરું
એક આઈટમ બનાવી છે એની માટે બોલમાં રાખેલું છે
પણ આવશે જ હવે એને કહી દઈશ તો હું અહીંયા આવી આઈ એમ સિટિંગ હિયર ના આઈ ટેલ હિમ Okay, bye. All right, sorry. So that is about. Oh, we are done with the ECGs. All right. So these are the important ECGs. You guys got it right? Any questions so far?
No.
No.
Everybody? Good?
Yeah.
Yes, good.
I think I have a question.
Yeah, go ahead.
I've I've heard irregular. I don't know if it has anything to do with this, but what is irregularly irregular?
Okay. So one, I mean, irregular means just irregular. That it is um
If it's not important, it's okay. I just
no,
I
I'm just to find the right word to frame it. Basically, there is nothing called regularly irregular, but maybe regularly irregular would be where okay, let me not assume, but irregularly irregular is something which is you cannot even predict. It's just constantly irregular. It's not like that, okay, after three common beats there is going to be some irregularity. It's constantly irregular. I think irregularly irregular is used for atrial fibrillation only, right?
yes.
Yeah.
Where did you read that? Atrial fibrillation?
Mm, I can't think of specifically, but every time it comes up, I get confused. But I really thought that it was what you're saying. It's just irregular.
Yeah, it's just irregular. It's just a simple wordplay, but and I haven't seen a significant um
Like a vignette or anything like
significance about, yeah, irregularly irregular or regularly irregular, something like that. I haven't ever
that.
noted.
Okay.
Um,
Thank you.
I have a question as well.
yes,
We
go
talked
ahead.
in the beginning. We talked about that there'll be PR interval and then a dip before the QRS. I missed that. What was that for?
That was for oh yeah, the dip was the septum contracting, ventricular, the interventricular
Oh, okay.
septum, that when contracts that brings that dip, and then after transmitting the impulses the QRS begins, the when the
Okay.
ventricles contract. Okay, so that
Thank
dip is septum contracting. Yeah, so this is where this is written. Where did it go? Did I find that out? Yeah, R2R intervals are irregular. Rate is variable. Yeah, weight is variable. Okay, so I think maybe it's like rate and rhythm both are like irregular. That is irregularly irregular. Anyways, it's just irregular. Oh my god, I'm saying this word so many times, I'm going crazy. Yeah, it's just that the rate is variable. It can be tricky. I get it. Ha, thank God I get it. So what they are trying to say is what I said, rate and rhythm both are irregular. That is why it is called irregularly irregular. Means the rate, it's not necessary that it is always techie. Like you can see, it is bready at this point. Then it is normal. Then it is techie again. Then again it's normal. So the rate is also irregular, and clearly the rhythm is irregular.
Oh,
Yeah.
okay.
Yeah.
Got it.
So
Yes.
I think that is the meaning of irregularly irregular.
Okay. Thank you. I appreciate it.
Yeah. All right. So this is done. Now, based on this, let's do the theory part of it. Okay. So starting with AV blocks. All right. About AV blocks, can you guys tell me what is the treatment? AV. Okay, I'm sorry. All right. One of you, Tazeen, can you quickly tell me? Can you guys see the screen?
Yes.
Yes.
You can see the notes, right?
Yes.
All right. Tazeen, very quickly, can you tell me the three types of AV blocks? Just quickly brush up. Not in the book. Try to remember. Tazeen, is she there? No. Why are people not replying to me? You guys can hear me, right?
Yes.
Oh, now you are replying. Okay, so the rest nobody can hear me.
We can hear.
Yes, we
Okay.
can hear you.
All right. Okay. Okay, great. Bayram, then can you do you want to tell me the three types of AV blocks?
Yes. AV blocks. First degree
Hmm.
AV block. Second
Okay.
degree, which includes movies type 1 and type 2. And there is then third degree.
Okay. So what is the ECG finding that you see in the first degree AV block?
In first degree AV block, there is just PR prolongation.
Very good.
And in type 1 second degree, there is PR prolongation consecutively, matlab, with increasing
Yeah.
sequence, and then there is a QRS drop. And
Very
in
good.
type 2, there is a random QRS drop.
Very
And
good.
in type 3, there is AV dissociation. Ventricles and atria contract to different in their own
Very good.
sequence.
Yes. Perfect. Perfect. All right.
Thank
So
you.
perfect. Then anybody can tell me what is the treatment of AV block? Let's start with first degree. Anybody knows the treatment management?
We
Observe.
observe.
Very good, superb. High yield. This is like super high yield. I told you for step two, they are focusing a lot on the questions where the answer is just supportive or observe, and those kind of things. So type one, just observe. Type Mobitz type two in the, I mean, type two block in that Mobitz type one and two. What is the management for type one?
We observe.
Superb.
Observe.
Observe. Okay, that is also you will. Then what is the treatment for type two? Mobitz type two.
Pacemaker.
Very good. Per permanent pacemaker placement. Okay, permanent pacemaker. This is also you will. And third degree AV treatment is
Again, ICD placement.
yes, pacemaker.
It's me.
Okay. Which condition is associated with? I mean, in which other condition do you see third degree AV block? Sorry,
Brenda, we can't see what you're writing.
you cannot see what I'm writing.
No.
Yeah.
So what do you see then?
Nothing.
Blank.
Blank
Oh,
page. Plain note.
a blank page. Oh, all right. Mm-mm-mm. Oh, thank God Tazeen is recording the class because I totally forgot to record today's class. Thank God. All right. Now, can you guys see the screen?
Yes.
Okay. Can you guys see the notes?
Yeah, yeah.
Yeah.
All right. So I was just writing whatever we were talking. First degree AV block observe. Second degree in that Mobitz type 1 observe. Type 2 pacemaker placement. And third pacemaker placement. I asked you in which condition you see AV block.
Syphilis?
Okay.
Uh-oh.
Is there
Is it
AV
mine?
block? Lyme disease. Yeah. Lyme you
Lines.
see AV, right?
Oh.
Lyme's disease you see AV block. That is also important. All right. So management of AV block was important. You guys are already familiar with it. Now tell me, let's quickly talk about atrial fibrillation. Very high yield topic, but easy. So atrial fibrillation and flutter. Remember the origins. Do you guys know where it originates in the heart? Fibrillation
SA
originates
note.
where?
Uh,
Fibrillation.
fib- Fibrillation.
Oh,
Yeah, yeah, yeah,
Go ahead.
yeah. The pulmonary veins, ostia.
Yes.
Very good. Pulmonary veins, right? Not veins, pulmonary arteries. Pulmonary arteries, when they meet the left
Yeah,
atrium,
yeah, yeah, yeah,
yes,
yeah, yeah.
yeah. So pulmonary
Yes.
vessels, when they meet the left atrium, this junction, this point basically gives rise to atrial fibrillation. And which point gives rise to flutter?
tricuspid.
Very good. Go ahead.
Isthmus, maybe.
Very good. So this tricuspid valve is there, and then there is an inferior vena cava which would be going somewhere here. So the area between this, it is called cavo-tricuspid isthmus. Distance, I mean the space in between vena cava and this tricuspid valve, which is this area, gives rise to atrial flutter, which is called cavo-tricuspid isthmus. Got it? Both of these are just one-liner questions. You have to have an idea about both of them. All right. Talking about atrial fibrillation, can anybody tell me what is the patient presentation?
Palpitations,
Very good. Okay. Then,
chest pain,
so if I say that if patient presentation wise, how can you differentiate atrial fibrillation versus ventricular tachycardia? Just by clinical features. ECG is not given. Both
They'll be
patients will say, I am having palpitations, my heart is racing. Right? Both the patients will say like that. What are the other things?
uh, pulse irregular.
Okay, but again, that all right, irregular pulse, but that you need ECG for that. I mean,
dizziness.
okay, dizziness. In which one?
In
And
ventricular tachycardia.
ventricular tachycardia.
Very good. So remember like this. Basically, ventricular tachycardia is something more severe. Okay, so the patient is going to have intermittent palpitations, which is common in both. That is why this question is confusing. But tachycardia will have something else like syncope, chest pain, or dizziness. Some other findings will be there. Whereas atrial fibrillation patient can be absolutely asymptomatic. Okay, asymptomatic, no symptoms, just palpitation. A question, simple one liner question. A young patient coming to you saying that my heart is racing, no other signs and symptoms, and that's it, that's the question. And then you have options. Now racing heart can be two things: ventricular tachycardia or atrial fibrillation, right? So at that point, remember this, that AFib can be asymptomatic. AFib can be asymptomatic. All right. And ventricular tachycardia will have more signs and symptoms: dizziness, syncope, pre-syncope, chest discomfort, and whatnot. Got it?
Yes.
Got.
All right. Then talking about the management of atrial fibrillation. So tell me, what are the few things that you can do for the management? Any idea?
Rate control.
Very good. Two things you always keep in mind. One is rate control and second is rhythm control. Right. So what do you do for the rate control?
Beta
Beta
blockers.
blockers,
Beta.
Superb. Beta blockers. Then what else?
calcium channel blocker.
Calcium channel.
Very good. So beta blockers, calcium channel blockers, or you can go for digoxin, but always your answer is going to be between these two, whatever is given in the option. So
Mm.
rate control, beta blocker. Now, one more thing. If this is the case when the patient is hemodynamically stable, that I'll give them the medication. What if a patient coming to me is hemodynamically unstable?
Cardioversion.
Cardioversion.
Wow, you guys are
yeah,
so already okay. So always remember, whenever a patient,
synchronized.
any unstable patient is coming to you, very good. Synchronized cardioversion, right? Synchronized cardioversion is your answer. Cardiac patient coming to you with AFib, just check one thing: hemodynamical stability. Unstable, then don't think further. Synchronized cardioversion. If the patient is stable, then beta blocker or CCB. All right, clear with this one?
Yes.
Yes.
All right. Always remember one more thing. There is one more medication that we majority times add in AFib patient. What is it?
That is warfarin.
Anticoagulation.
Very good. Very good. Everybody is right. Anticoagulation. You always add anticoagulation. Is there something to calculate? Like, do you give it on all the patients?
Yes. No, we have to
Chadbas.
calculate INR.
Not okay. For warfarin, you are saying INR, but to give anticoagulation, you take
Chadbas
the
score.
Yes, very
Yes.
good. Not every, this is a very tricky question they give it, and I've got it wrong multiple times. Whenever I see atrial fibrillation, I get excited and I go for anticoagulation. Don't do that. You always have to first calculate the Chadsworth score and then only give anticoagulation. Okay. So let's do the Chadsworth score. What is C? This is a mnemonic for something, right? Yeah, congestive heart failure. Then
Congestive heart failure, hypertension,
okay, very good.
this age,
Age more than 75.
75, 2
75,
points. Hmm.
diabetes mellitus,
Very good. Very good. Stroke or TIA
TIA,
or any thromboembolism, 2 points.
Any vascular disease?
Very good. Any vascular diseases
vascular
like
disease,
prior MI, peripheral artery disease, aortic, whatever, any vascular basically. Yeah. Then A,
Age again.
age again for more
very
than
good.
65,
1 point. Then
then sex,
if female, right?
females, yeah.
So that is the Chadsworth score. Now, if the score is 0, then you don't have to give any anticoagulation therapy. If the patient has AFib, but there is none of this. So the young patient that I'm talking about, in them you don't go for anticoagulation. Okay. So
Okay.
if the score is 1, usually they say like if 1, then none or aspirin or oral anticoagulant. Okay. But I have seen MCQs where if it's 0, then none, and 1, then you always go for anticoagulant. More than 2, then 100% anticoagulant. But this is optional. But I would still prefer that you start with oral anticoagulant if the score is 1 or more than equal to 1. What are the oral anticoagulant that you prefer?
Rivaroxaban,
Very good. So always remember that
water,
direct 10A inhibitors, newer anticoagulants are always preferred over heparin and warfarin in the options also. Okay, so if they have given all these options, then go for NOAC in terms of anticoagulation for AFib. Direct 10A inhibitors, which is apixaban, rivaroxaban, edoxaban, or direct thrombin inhibitors also you can go for, which is what dabigatran and all those things. Clear?
Yes.
But always prefer NOAC. All right. Warfarin, okay, there is a key point here. Valvular atrial fibrillation or mechanical prosthetic valve is there. Then you have to go for warfarin. Otherwise, NOAC. Okay.
yeah.
If there
Yes.
is mechanical or prosthetic valve, then you go for warfarin. Otherwise, NOAC. All right. Mm-mm-mm. Then what? Oh, they have not given flutter along with this. Yeah, but let's finish flutter because we did fibrillation. So flutter, most common origin site we just saw, cavo-tricuspid isthmus. What is the treatment of flutter? Same only, no? Atrial
Yeah,
flutter and
rate
fibrillation
control,
both. You have to go for rate control,
rate
rhythm control.
control and rhythm control,
Yeah, beta blocker or CCB. Okay, and
PCBs,
treatment
yes.
will always include a chronic anticoagulation therapy. Okay. Most commonly, flutter is going to be seen in a higher age group, patient with hypertension or any heart failure and those things. I have just seen a few flutter questions. They are very easy. Sawtooth appearance is given and you get it. And anyways, the management of both of these is easy. Okay. Trick part is the trick, uh, high yield topic is the supraventricular tachycardia. Now, there are a lot of tachycardias which fall under the category of supraventricular tachycardia. Okay, there sinus tachycardia is also supraventricular, multifocal atrial tachycardia, flutter, fibrillation, AV nodal reentrant tachycardia, all the names that you know falls under the umbrella of supraventricular tachycardia. Okay. Now, in that, the main one is paroxysmal supraventricular tachycardia, which is also a subtype of SVT, where like there is abrupt onset and offset. But again, it can include any of these that I said above. So for this, the management is what? For paroxysmal supraventricular tachycardia, there is a specific thing we do.
Carotid massage.
Yeah. Why do you do carotid massage? Can you tell me?
Increase the sympathetic
Parasympathetic
sympathetic.
response.
No, why do you want sympathetic response? When you stimulate carotid, actually you trigger the parasympathetic,
Yeah,
Yes.
increase in the
right?
parasympathetic response.
Yes. So when you trigger the carotid, it will trigger the parasympathetic response, which will go to the heart and slow the conduction pathway, right?
Yes.
Yeah,
So that is what we want. We want to temporarily slow the AV nodal conduction pathway. Why? So that we get the time to read the ECG correctly. Okay, once again, paroxysmal supraventricular tachycardia. You remember how the ECG looked like? There is this wave, then there is something like this T wave, and then there is again this wave, and then we had this T wave. So this is the one where I told you that there is a P wave which is hidden under the T wave, right?
yeah,
So what we want to do is, because this heart is beating so fast, we want to slow it down so that we can uncover that hidden P wave, and we can differentiate that what kind of actual ventricular tachycardia is going on, whether actually there is a P wave present or not, or whether it's AV nodal reentrant tachycardia, or whatever it is, right? So main purpose is we want to slow down this whole ECG so we can read it correctly and differentiate which kind of tachycardia is going on. Make sense?
Yes.
yeah,
Right? So
Yeah.
always, in case of supraventricular tachycardia where you cannot see the P wave, you want to slow down the ECG. Remember it like that. So you want to slow down the ECG, uncover the P wave, you can read it and confirm it. So number first thing that you have to do in them is vagal maneuvers. Okay, vagal maneuvers include carotid massage, include eyeball pressure, include valsalva maneuver, includes inserting face in cold water, which is also very high yield UL question. And the question is, why do you insert the patient's face in cold water? The mechanism of action is asked, and the answer is what? Slows the AV nodal conduction. You guys know that how it does it, right? The parasympathetic activates, parasympathetic goes to the heart, and it decreases the conduction.
yeah.
Clear?
Yes.
Okay. Here
Yeah.
also, same mechanism. What if the patient is hemodynamically unstable?
Synchronized cardioversion.
Yeah.
Synchronized cardioversion.
Immediate
Synchronized.
synchronized direct current cardioversion. No, no thinking, like nothing doing anything else. Going for first synchronized cardioversion. Okay. Now, what if a patient does not respond to this vagal maneuvers? Then what next would you do?
Adenosine.
Adenosine.
Okay, very good. What if adenosine is also not helping?
Cardioversion?
No. Hemodynamically
Wait,
stable.
after
Then what to do?
you said after if carotid massage doesn't work?
Yeah,
And
carotid massage you tried, nothing is helping. Adenosine you gave, not helping. Patient is still stable. Then if you don't know anything, okay, remember this trick. If you don't know anything in case of tachycardic patients and you are clueless, always go for beta blocker or CCB. Okay. Here, I just wanted to make this a point that beta blocker and CCP is the last preferred choice when everything fails. For these paroxysmal supraventricular tachycardia patient, you need some abortive therapy, which is vagal maneuver. Clear?
Yeah,
Yes. Yeah.
Everybody clear, right?
Yes.
yeah,
Yes.
Yeah.
Okay. Now we are doing, because you guys have got the basic idea, we are doing the main chart, life-saving chart on tachycardia, adult tachycardia patient. All right. So, starting with sinus tachycardia. You guys only have to answer because now you know this, the details. So if there is sinus tachycardia, then just look for underlying cause and treat the underlying thing. Don't start any medications. All right, lifestyle modification. But if that is not the case, then next check hemodynamic stability. If the patient is unstable, then what?
Synchronized
Synchronized cardioversion.
Synchronized cardioversion. What if the patient is stable? Then what next would you do? Anything else that you want to check?
If it's wide complex or narrow complex QRS.
Super. The next thing you want to check is the QRS. All right. You know that there's tachycardia. Now, next thing you have to check after hemodynamic stability is the QRS. Whether the QRS is wide or not. If 0.12 is normal, if it is more than 0.12 means it is wide. Yes, it is wide. Then next thing you want to check is what?
Rate and rhythm.
Rhythm. Okay, very good. QRS is wide. Yes. Next thing, check the rhythm. Now, rhythm is showing that it is regular. Okay, regular. Then what type of tachycardia it is?
Ventricular tachycardia.
Which ventricular tachycardia? We are talking about all ventricular tachycardia, but which ventricular tachycardia?
Mono.
Monomorphic.
Morphic.
Very good. Monomorphic
Monomorphic.
ventricular tachycardia. Right? If the QRS are wide and the rhythm is regular, means same interval, that is monomorphic ventricular tachycardia. Clear?
Yes.
But if the rhythm is irregular and the QRS is wide, then it is,
Polymorphic.
oh yeah, it can be polymorphic. Yeah, it is polymorphic. And there is one more which is called possible atrial fibrillation with aberrant conduction pathway.
Mm.
Okay. All right. But majority question is on the management. So let's talk about the management. If the rhythm is regular and what is it? Wide QRS, then it is monomorphic. What is the management? What is the drug name? Preferred drug.
Amiodarone.
Amiodarone.
Yes, mug it up. Amiodarone is the first line management of monomorphic ventricular tachycardia, high yield. What is the management for this one? When it is irregular, antiarrhythmic. Any antiarrhythmic. You can go for prokinamide, ibutalide, whatever. No UL question on this one, but still you should have an idea. All right. All right. Then if the QRS complex is normal or narrow, then again check the rhythm. Now, if the rhythm is regular, narrow and regular, so what do you think it is? Narrow and regular, something like this. What is it?
Atrial flutter.
Sorry?
Atrial flutter.
No.
Supraventricular tachycardia.
Supraventricular tachycardia. Very good. Supraventricular tachycardia. Remember, supraventricular, you forgot how it looked? It looked like this, no? I mean, okay, I'm not drawing it perfectly, but something like this, right? Narrow QRS and quick, and regular rhythm, right? Forgot or what, everybody?
Yes.
No.
Confusing.
If there's any confusion, please let me know, okay? So what is the management for supraventricular tachycardia?
Adenosine or vagal maneuvers.
Vagal maneuvers or adenosine. And if the rhythm is not regular, then what is it?
AFib.
Yeah, then it is AFib or flutter, right? And the treatment is what?
Rate control.
Beta blockers.
Beta
Yeah.
blockers.
Calcium channel blockers.
Okay. So this chart is very high yield because it sums up all the tachycardia issues and like super high yield. There is 100% a question from this chart. Super high. So anybody has any problem anywhere in the chart, this is the time. Any questions? No?
No.
Okay,
No.
great. Yeah. No? We'll revise the chart, don't worry. But let's take a break and then somewhere around the end we'll revise the chart because it's high. All right, then we have already discussed this question earlier, but it is there in front of me. So I'll ask you, what is the approach for a patient with sinus bradycardia? Patient
That's
has
rotating.
sinus. Oh, perfect. Yeah, sinus bradycardia, hypotension, chest discomfort, like basically brady, which is less than 50 heart rate. Then first thing to give is atropine.
Ibuprofen.
Yes, very good. That's main thing. All right. Okay. All right. Just one thing. I'm actually hearing some disturbance kind of thing. Can everybody just mute themselves? All right. Perfect. Thank you. Okay. This is a small topic but very high. It is called wow, sick sinus syndrome. Sick sinus syndrome. As the word suggests, the patient is sick means very very old and the sinus is now sick. So in old people, elderly people, you see this condition called sick sinus syndrome. Because of age, their nodes have they are not working properly. You can say the SA node and the AV node, they have degenerated or fibrosed. Okay, so degeneration of nodes is nothing but sick sinus syndrome. How is the presentation? The classic present. Just remember two things: old age and bradytachyarrhythmia. Mixture of both brady and tachy. Brady plus tachy, that is sick sinus because the sinus is sick. So sometimes it's over running, sometimes it's slowly walking. That is brady plus tachy seen in old age. All right, that is sick sinus syndrome. Nothing else. Questions are what is the pathophysio? How is there bradytachy? Both. The answer is cardiac conduction system degeneration or SA node degeneration, impaired SA node, those kind of options. All right. Then let's talk about a few peculiar abnormalities like Wolff Parkinson White syndrome. One things we just have to remember the management for them, the treatment drug names for each of these. So Wolff Parkinson White syndrome. You guys remember this? The most easy ECG, according to me, when I was doing step 1, was this Wolff Parkinson White because there was this thing called delta wave. Most easy to catch on the ECG, right? Delta wave. So that is nothing but Wolff Parkinson White syndrome because of an accessory conduction pathway where instead of going through the nodes, the impulses are directly getting conducted from the atria to the ventricle, jumping directly to the ventricle. That is why there is this extra wave called delta wave. All right. What is the treatment? Drug name. Any guesses? Anybody knows? Which one?
Propanamide?
Sorry?
Propanamide.
Very good. Procainamide. Procainamide is the drug of choice for Wolff Parkinson White syndrome. All right. What was the drug of choice for monomorphic ventricular tachycardia?
Amidarone.
Amiodarone. Very good.
Um,
Super. Very good. Then we have something called long QT syndrome. Can you guys tell me a few drugs which causes long QT syndrome or QT prolongation?
Antipsychotics.
There is this mnemonic called AA, B, C, D, E, right?
Yes.
So antipsychotics, then
Azole antifungals.
very good. Antipsychotics, azole, antifungals.
No.
Antibiotics like fluoroquinolones.
Fluoroquinolones.
Yes.
Yes.
Then
as
Oh, yeah.
quinine.
Just a second. I'm just thinking about the azoles that you said earlier. I have to check that. Was it there? Was
Yeah,
it
it is there.
okay? Yeah. Anti-infective will have azoles as well. Yeah, macrolides, fluoroquinolones, and antifungals. Okay. So it will be here antibiotics or anti-infectious. Then
Anti-arithmetics.
very good. Anti-arrhythmics. Which one?
Quinine.
Quinine,
1A and 3.
Very good. 1A and
1A
3.
and 3.
So
Yes.
1A is quinidine, procainamide, and isopyramide. And 3A is sotalol and ibutylide. Okay. Then what else? Actually, this is antibiotics here. Yeah. This is 1A. This is 3. Yeah. Then these two, what are they?
Antidiuretics. لا, antidepressants.
Antidepressants.
Antidepressant.
Yeah. Antidepressants. And one more.
Antiemetics.
Very
Yes.
good. Antiemetics.
Antidepressant.
Okay, so mugging up these antibiotics, I mean, this ABCD is important for long QT syndrome. Then you remember something called Jarvell-Lange-Nielsen syndrome. In step 1, we had it. Remember Jarvell-Lange-Nielsen
Yeah.
syndrome, which is congenital long QT syndrome.
QT
These
syndrome.
are all acquired long QT, right? They are going to prolong because of this outer factors. There is something called congenital long QT, which is Jarvell-Lange-Nielsen syndrome. There is a classic thing about it. Anybody remembers what is it? Classic.
Hearing loss. Hearing loss.
Very good.
Sensory neural
Sensory
hearing
neural.
loss.
Yes, sensory neural hearing loss. In a patient, sensory neural hearing loss in a patient with long QT approximately around 600 till 400 it is normal, 400 or 450 above it is abnormal. So yeah, more than 450, here it is 600 plus patient with sensory neural, then you have to think of Jarvell-Lange-Nielsen syndrome. What is the treatment? Any idea? Management? Drug?
Or
Is it? Beta
Beta block.
I'm not able to catch one word.
Is it beta blocker?
Beta.
Yeah. Yes. When in doubt, go for beta blocker. One condition where you don't go for beta blocker in cardio, never go for beta blocker in cardio. We did it yesterday.
Cocaine
In.
thing. MI.
Cocaine induced MI. Cocaine
Yeah.
induced MI. Perfect. All right. So
okay,
here the man.
what?
Cocaine induced MI, myocardial infarction.
Oh yes, yes.
Yeah. And what was the other instead of beta blockers? Now something else you will add. So what is that?
Benzodiazepine.
Benzos.
Benzodiazepine.
Yeah. Remove one B, add one B. Benzos. All right. Perfect. So here the treatment is beta blocker. So very quickly, what was the treatment of monomorphic ventricular tachycardia?
Amiodarone.
Very
Amiodarone.
good. What is the treatment for Wolff Parkinson White syndrome?
Procainamide.
Procainamide.
Amyloid.
Very good. What is the treatment for long QT?
Beta
Beta blocker.
Beta blockers.
Very good. And if a patient who has like syncopal episodes and refractory to any management, they will need long-term pacemaker placement also for this long QT. Okay. All right. And last is a torsade points, which is your favorite, right? This is torsade points. What is the um, management? The management will answer the question of what is the cause. So, what is the management of torsade points?
magnesium.
Yeah. So main problem with torsade point is what? The electrolyte abnormalities,
Yeah.
right?
Yeah.
Hello.
Hypokalemia, hypomagnesemia.
Very good. Very good. That is why the treatment is going to be magnesium sulfate.
Mhm.
So each of this is asked in UWorld once one like the one-liner treatment. So don't forget that. Torsade points, magnesium sulfate, long QT beta blocker, monomorphic amiodarone, and procainamide for Wolff Parkinson White.
What was your reason for magnesium sulfate?
because there is electrolyte abnormalities. Now whenever
Oh,
there is low potassium, you should know for any situation, okay, any situation in the body, like for chronic alcoholic patients where potassium is low, so whenever you want to replenish potassium, you should know that you have to give magnesium first. That is the one that will bring the potassium also back to normal, right?
yeah.
So yeah, magnesium sulfate. All right, we actually missed one topic yesterday and quickly jumped to today's AV ECG thing. So let's quickly go back and finish that. And it was, we did pericarditis. So a few more topics, okay? I hope you guys are breathing and alive. All right, very important chart, but easy. Cardiac arrest. If a patient is coming to you who is in cardiac arrest, so how do you approach that patient? So just imagine you are in ER and a patient is coming to you with like chest pain, crunching chest pain, and you put an ECG and you can see that the patient is in VFib. Okay, when you see the patient is in VFib or has ventricular tachycardia, you first shock the patient, right? Like in movies, or good that if you have seen in real life as well, shock the patient. Second thing, you start immediately, you start the CPR, 2 minutes, you obtain that IV access and everything, and again you check whether the rhythm is shockable or not. If yes, you see a rhythm, then again shock the patient. Okay, after the second shock, nothing is happening, then repeat that CPR. You have to keep on continuing the CPR. But the new thing added here at this point, which is high yield and new world, is epinephrine. So shock the patient, check for the shockable rhythm, shock the patient, nothing happening, add epinephrine. Every 3 to 5 minutes, you can keep on repeating and giving epinephrine. All right. Then again, check for the shockable rhythm there or not. If yes, then of course shock the patient. Again, repeat that, like we said, 3 to 5 minutes. You can keep on repeating that cycle. Last thing is that if everything has failed, multiple rounds of epinephrine not helping, then you give them amiodarone, which is also the management for monomorphic ventricular tachycardia. So amiodarone, you add amiodarone, again shockable rhythm or not, and that loop is continued. So main thing, cardiac arrest, VFib, shock, shockable rhythm there or not, shock the patient, shock, not helping, epinephrine, shock epinephrine, not helping, amiodarone. You will high yield. All right. Another important thing in this chart, if a patient comes to you with cardiac arrest and has asystole or pulseless electric activity, okay, pulseless electric activity. So always remember in them, never ever shock this patient. Okay, patient with asystole or pulseless electric activity, never shock the patient. You always just go for CPR, IV access, and directly epinephrine. Give that 3 to 5 minutes also, like every 3 to 5 minutes. Then check for the shockable rhythm. You can shock, then of course if you get the rhythm back, then you can shock them, and then you can follow this path. But if you don't get the shockable rhythm, then keep on repeating this. Clear, everybody?
Yes.
Yes.
No doubts, right?
Yes.
All right, so that's
Yes.
three high yield questions over here. VFib, shock, epinephrine shock, not helping amiodarone, and asystole or pulseless electric activity, then no shock, give epinephrine. All right. I need to hear from somebody. Reversible causes of asystole or pulseless electric activity. Anybody knows the 5H and 5T's? Causes of pulseless electric activity.
So it is a hypovolemia,
Very good. Hypovolemia.
hypokalemia, or hyperkalemia.
Hypokalemia. Oh, oh yeah. You said kalemia, but in my mind it was calcemia. Okay. Yeah, hypo or hyperkalemia. Potassium, basically. Okay.
Yeah. Acidosis, hydrogen ions.
Very good. Hydrogen ion.
Then hypothermia
Hypothermia. Very good.
and hypoxia.
Hypoxia. Very good. So low oxygen, low temperature, low blood pressure, potassium and acidosis, that is reversible cause of asystole, the H. Then T's. What are the T's?
Tension pneumothorax,
Tension pneumothorax.
cardiac tamponade,
Tamponade. Okay.
then
Thrombus.
trauma
Very good. Very good. Thrombosis, trauma, and toxins.
and toxins. Yeah.
Yeah. Haven't seen question on this, but this is important. Okay. All right. Okay. Again. All right. So about syncope also very easy. Lot of questions, but easy. It is divided into a lot of types of syncope. I would just like to focus on three important ones, which is vasovagal and cardiac. Third is the easy one, which is seizure. And there is a fourth different type, which is psychogenic pseudo syncope. Okay, but important is to differentiate between vasovagal and cardiac. Okay, so vasovagal, as the word suggests, that this is because of the vagal stimulation that the parasympathetic gets activated and the heart is slowed down, and the patient uh, loses consciousness for a while. So anything that is going to trigger the vagus nerve, going to activate the parasympathetic or block the sympathetic, are a few things like prolonged standing, emotional distress, any painful stimuli, right? Some kind of trigger will be there. And another high yield thing that will differentiate this with everything else is a prodrome. There has to be nausea, warmth,
Mm.
diaphoresis, vomiting, anything. The patient won't be like, okay, I just felt like that. No, there will always be, I started feeling little nauseated, sweating, diaphoretic, or warmth, and then I passed out. Okay, something 100% will be given at the question. If that is given, that is vasovagal. If nothing is given, the patient, it is mentioned that just like that collapsed, no preceding signs and symptoms, means it is cardiac. Okay. No warning signs is cardiac. Warning signs present is vasovagal. Clear? Now in cardiac, we can have multiple types like arrhythmias. So that patient can have palpitations. There can be bradyarrhythmias, old patients. Where do you see bradyarrhythmias? Bradytachyarrhythmias, sorry. Where do you see them?
Right, am I?
Right, MIF.
Bradyarrhythmias you see in right MI, that is right. Bradytachyarrhythmias, where do you see that?
6 sides.
Superb. 6 sinus syndrome, right? Old patients where the AV node, SA nodal conduction system is has become weak. So it's sometimes over pump, sometimes under pump. So ready, techie, both. All right. And AV blocks. In AV blocks also there is going to be syncope, but that will be again seen on the ECG, the PR prolongation, the QRS drop, and everything. So all these are the cardiac conditions. Main thing is differentiate vasovagal versus cardiac. Got it?
Okay.
Yes. Yes.
All right. Seizure. Now, how would you differentiate? What are the differentiating points between seizures and syncope? Quickly, tell me.
Seizures, they will be confused afterwards, and it will take
Superb.
time to.
Very good. Post-ictal phase is going to be long. Then,
The aura,
very good.
Yes.
Very good. Superb. Here there is aura. Here there is a prodrome.
Mm.
Different. Aura can be tactile, visual, smell, something, olfactory hallucinations. That is aura. This is prodrome. Then,
The tongue biting.
very good. Tongue biting. Now, this is a confusing question where they gave tongue biting and the answer was syncope. So, rare case because other symptoms were still easy, so it is syncope. But here also it can be there, very rare. but frontal tongue biting would be there, and here lateral would be more common. If given, and if you want to like 100% be sure, then just remember this, that tongue biting can be there over here, but it is rare. Then
Okay.
You have
Um,
movements, seizures, and syncope not necessary.
very good, very good. Convulsions would be there, right? Convulsive movement where the patient is that the seizure patient that we typically see, that is going to be there in seizures, whereas syncope, very rare, like very rare can be there. Usually it's not there, so that is there. So main things are this, right? Postictal phase is longer over here, aura is there, prodrome is there, tongue biting is there, commonly here lateral, and convulsions. Got it? That is seizure. And last thing that I mentioned was psychogenic syncope. So psychogenic is, as the word suggests, that the patient actually does not have anything, but they are just lying unconscious. They don't. They are actually totally awake, but due to something, it's psychogenic, as the word suggests. We don't know what is causing it, but they are completely aware. Typical features that will help you differentiate is this is longer. Real syncope lasts for 1 to 2 minutes, not more than that. But psychogenic syncope is 10 to 20 minutes. Another thing, syncope, the real one, the patient does not know how their body is because they have completely lost consciousness. Whereas these patients, they would be able to describe you that while I was unconscious, I could feel my leg moving this way, or I could feel my hands going numb. This something they will describe during the episode, which is unusual. Okay, so that is there. Reports symptoms during the event, which clearly states that they were aware, so it's not a true syncope. And the third is yeah, any absence of objective findings like pallor, sweating, abnormal vitals, those kind of things. But I think it's a giveaway over here. Only 10 to 20 minutes means it's not syncope. Got it?
yes.
Yes.
Any questions so far?
No.
No.
Anybody? No?
No.
Okay.
No.
Then there is something similar to this is orthostatic hypotension, right? What is the mechanism of action behind orthostatic hypotension?
Decrease blood flow to the brain.
Very good. And there is mainly a drop in the systolic BP of more than 20 and diastolic BP more than 10. Most commonly seen in which age group?
Elderly.
Elderly. So why in elderly there is something peculiar happening over there that they are having this?
Autonomic dysfunction.
Very good. Decreased baroreceptor sensitivity. Okay. Decreased baroreceptor sensitivity, that is causing decrease in the intravascular volume, hypovolemia. It can be most commonly because of any associated medications that they are taking. And yeah, but this is you will decreased baroreceptor sensitivity because of old age. And anything else? No. Okay. Clear up till now? Syncope,
Yes.
PAD, and everything got it? All right, then with the basic feeds. So first of all, whenever you have a neonatal patient, when a newborn is uh, there is a newborn, what are the first few things that you check in a newborn? Tell me.
Do we check for
The
APGA?
APGAR score.
Okay,
APGA
very
score.
good. Yes. What else?
There is what else? What would it be? The breathing pattern, the
Mhm.
anatomy is anatomically is okay.
Yes. Oh, I don't know why this is happening. Can you guys still see the screen or not?
Yeah, you just wrote newborn screen. Yes.
No, no. Can you guys see my notes screen where I was writing?
Yes.
Yeah.
Really? Uh, okay, can you see what I'm writing right now?
No, you are not writing. You only wrote newborn screen.
Yeah, that's what I thought. They just abruptly stopped the recording. Sharing. Let me share it again. Okay, yeah. So you guys mentioned Apgar score, then checking if there are any anatomical defects or not. Right. What else?
Then after that, then we we have to like to auscultate the baby, the newborn, and auscultation.
Anything else?
The breathing pattern, the number, the I mean that comes under Apgar. So
Yeah.
mm,
So I would divide it like this, like five most important things that you have to screen. One is that should include the metabolic and genetic disorders. So for metabolic, for example, one very high you will question is on thyroid. If a baby has hypothyroidism, then you need to start them on thyroid hormone replacement therapy immediately, because once it progresses, if it is not started in 2 weeks, then there is going to be permanent intellectual disability. So always in newborn screen, you want to include metabolic and genetic disorders, right? This is like, obviously you don't do it for each and every newborn. It's just like a rough check. But if, for example, a mother has thyroid issues or there is some genetic defect running in the family, then you, like for sure you will check in them. But metabolic specifically to rule out hypothyroid, because if not corrected within 2 weeks, in less than 2 weeks, not corrected, then permanent intellectual disability. So that was one high yield point for this one. Other things are going to be like hearing screen, right? You want to check their ears, then you want to double check hyperbilirubinemia. If there is that, then underlying causes for that. Very high yield, another high yield point, just like this one, is checking pulse oximetry. Pulse oximetry, for example, they said that, okay, you check the pulse ox in the hands. What else would you do? Or what is, and everything is checked, then what is the best next step? The answer should not be nothing. The answer should be check it in postductal, means in either leg also, right? So you always want to check in arms and legs, both ways, right? Why do you check
Yes,
both arm and legs?
it's scanning of disease like
coarctation of the aorta.
coarctation of the aorta.
Super, very good. So congenital heart diseases like coarctation of aorta, pulmonary, it was, what was the term? Pulmonary
Transient
hypertension in newborn. The name of the,
hypertension. Yeah, the PPHN, right?
yeah,
Pulmonary.
persistent
Yeah, yeah,
pulmonary hypertension of newborn,
yeah.
right? So for these conditions, you always, this is another high yield point of view, pulse oximetry in both and legs. Okay, not just one. And lastly, hypoglycemia. So again, this is for selective patient. If the mother has diabetes, then you always want to check whether the baby has hypoglycemia or not, right? So check glucose. All right. I did not write the hearing thing, which I mentioned earlier. But these two are high yield U-word points. Any questions?
No.
Okay, perfect. All right, then basic newborn care is done. Now, another basic baseline thing we want to differentiate is if you hear a murmur, for example, in a newborn, how would you differentiate a normal physiologic murmur from a pathologic one? Any idea? How would you differentiate these two?
Yeah, I forgot. I don't remember.
That's okay.
Yeah.
Any rough guesses? Okay, let me give you a hint. Yeah, David, you want to try?
Just go on.
Okay, so for example, if I say, what should be the, what's the word? Mm, how should it sound? So if it is, for example, musical or vibratory, if these kind of words are given in the question, then it is not a pathologic murmur. Musical, vibratory murmur is a benign murmur. Okay. Harsh murmur, if the word harsh is given, that is a pathologic murmur. You guys can see what I'm writing, right?
Yes.
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 Okay. Other thing is, if there is early or mid systolic, murmur, again that is benign. But if you have holosystolic or diastolic murmur, any kind of holosystolic diastolic murmur, that is pathologic. Another thing is the grade of the murmur. Grade 1 to 2, again benign. More than 3, pathologic. Right?
Okay.
Yes.
Then after doing maneuvers like Valsalva maneuver or any maneuvers, if the murmur disappears or decreases in intensity, then again it is benign. But if the murmur persists after maneuvers also, it is pathologic. All right, so these are the easy points that they usually ask in the question. Something like there was a question with vibratory sound and grade 2, mid systolic. Now, when only these things you read in a question, they sound little, tricky, that you want to go for something pathologic. But it is all normal, right? It's all benign. You don't want to do anything. The treatment, the question would be, what would be the best next step or the treatment for this patient? Answer is reassurance, nothing else. All right.
For benign and physiologic murmurs, you're saying that the answer should be reassurance.
Reassurance, right?
Okay. Mm-hmm.
Yes. And for step 2, always remember, for step 2, there are so many questions where they focus on where one of the option is reassurance and doing nothing. So that is something that I used when you are in doubt in exam and you don't know anything. I would rather go for reassurance as an answer, because a lot of questions they are testing that you don't overdo something. So just a trick. All right. Then pathologic. Now, another trick part. For example, if I tell you that this patient is coming to me with signs like central cyanosis, and the liver size is 3 centimeter. Do you think it is concerning? The liver size is, no, wait. Sorry, I framed it wrong. Okay, if there is central cyanosis and the liver size is 4 centimeter, is it pathological condition or physiologic?
Pathologic?
I think whenever it's central, it's not good.
Very good. Exactly. So central cyanosis was the key. So if you have central and hepatomegaly of liver size more than 3 centimeter, means it is not equal, actually more than 3 means it is pathologic. You have to check for any underlying congenital cardiac condition. So central and hepatomegaly, but they tend to confuse you by giving this, that there is acrocyanosis. Acrocyanosis means cyanosis in the hands and feet.
Yes.
Just acrocyanosis and liver edge, for example, 3 centimeter. So that is also a little bit a hepatomegaly side, but in a newborn, it is considered normal. So this 3 is important. Okay. Liver edge normally palpated up to 3 centimeter in newborns. All right. Not in adults, but newborns, it is absolutely normal. So acrocyanosis, if given in question, and liver edge 3 centimeter means it is physiologic. Don't do anything. Clear?
Okay.
Okay, so it's supposed to be less than 3 centimeters. That's like the liver edge. Less than 3.
Less than 3. You're asking me or telling me?
So I'm just trying to.
It's less than equal to 3. It's less than equal to 3. So liver edge normally palpated up to 3 centimeters.
Okay.
Okay. All right. So in this case, whenever there is anything which looks pathologic, what is the best next step in management? Tell me, what do you do?
I think we do
Echo?
an echocardiogram.
Echocardiography.
Very good. Always the safest answer. Lot of questions, even in adult and newborn. Anything, best next step, you don't know. First is echo, right? So echocardiogram is the answer. And here in benign case, whatever things are given, then what is the best next step?
Reassurance.
Reassurance.
Superb. Reassurance. Right? So all this is UWorld, like major UWorld stuff. All right. Then coming to particular conditions, starting with, let me see, I want to take a favorite one. All right, starting with my favorite one, which is tricuspid atresia. What do you guys know about tricuspid atresia? What is the basic problem in tricuspid atresia? Tell me that.
It's
What
the
does the
one
name
which
suggest? Yeah.
it's the one which brings like the dilation of the right
Atrium.
atrium.
But what is the problem? You are right. But
Mhm.
But
what does the name
the
suggest?
the septal defect, like when the baby is being born, the what is it called? The cushions of the endocardial cushions are not properly made, or something like that. Is it that?
Yes. So, as the name suggests, tricuspid atresia means this tricuspid valve is absent. Okay.
Mm-hmm.
It's not there at all. So, just imagine in all these newborn conditions, just or any cardiac condition, just try to imagine what would happen. Now, for example, if this valve is not present, then from the right atrium, this is right side, left heart, right ventricle, left ventricle, the blood in the right atrium will not be able to go down, right?
Yes.
Because of that, what will happen? Eventually, buildup of pressure in the right atrium will increase the size of the right atrium, right?
Mhm.
On an ECG, when you do an ECG, the P wave is indicating of the atrial pressures, right? So
Yeah.
what will happen
Okay.
when the
Yeah.
atrial? Yes, tell me what will happen on
It's
an
got to
ECG.
go higher. It's got
Very
to.
good. So it's going to be tall peaked P waves. That is number one finding in tricuspid atresia. Tall P wave indicating right atrial pressure is high. Clear up till now?
Yeah.
All right. Now, if the blood is not going down, means this baby is surviving because of this ASD and VSD present in it. So what will happen? All this blood gets shunted to this side of the heart. When it gets shunted to the left side of the heart, the left atrium and eventually the left ventricle enlarges, right?
Okay.
So that is going to cause the second problem, which is left side volume overload. When you have a left side volume overload on an EKG, there is going to be left axis deviation in the leads. In short, left heart is affected. Now, eventually, because of all this, what is happening to this pulmonary valves? These pulmonary valves are not getting used at all because nothing coming this way, right? So as these pulmonary valves are not getting used, there is lack of development of the pulmonary valve, making them underdeveloped. Hence, pulmonic stenosis situation. And when you have pulmonic stenosis, means the blood is not going forward in that direction. There is going to be single S2, single second heart sound, right?
Okay. Yeah.
S2 is made of two components, aortic component and pulmonic component, right? So single
Yes.
S2 means that the aortic is working well, but because the pulmonic is taking so long and it is not working at all, you can just hear one heart sound, which is the aortic, hence single S2. Okay, clear up till now?
Can you go over
Yes.
the last point about the pulmonic stenosis?
Yeah, sure. Okay. So blood not entering from the right atrium to the right ventricle. So
Mm.
pulmonic valves are not getting used. They are underdeveloped. If they are underdeveloped, they are eventually get stenosed, right? So the
Mm.
situation that is created looks like pulmonary stenosis.
Okay.
Now about the heart sound. So there is single S2. Usually there is this two together forms heart sound number two.
Mm.
A2 and P2 component, right? Usually
Yeah.
A2 is
Yeah.
first, P2 is later on. P2 is
Later.
later on because it is collecting all the blood from the body is coming to the P2. So it takes little longer,
Mm.
right? But in this case, when it is not getting used at all, this component it is very, very late. Hence, because of this, only you hear one single S2.
Okay, that makes sense.
Right?
Mm.
Okay, so that was the third high yield point. First was what? Tall peak P wave. Second is
P
left
wave.
axis deviation. Third is
Mm.
single S2. Last is, again, because this pulmonary this pulmonary trunk is not getting used as much as it should be. The pulmonary vascular markings in the lungs are underdeveloped,
Mm.
right? Because those vessels are not getting used. So, fourth point is underdeveloped pulmonary vascular markings. Got it?
Okay.
Decreased pulmonary vascular markings. All right, so can you imagine the whole scenario? One valve is absent, hence backflow of blood in the right atrium, causing shift of blood to the left side of the heart. Left heart enlarges, nothing going in the right ventricle from the right atrium. Hence, the pulmonic valves are underdeveloped, causing single S2, no like minimal forward flow of blood in the pulmonary system. Hence, decreased pulmonary vascular markings. So in the question, maybe three of these things are given and they would ask the fourth point, or something would be missing out of these 4 points that you have to pick from the answer. Usually that is the question. Clear?
All right.
Everyone following?
Yeah.
Yeah, we are following.
Okay. Then the second topic is transposition of great vessels. So what do you, what do you infer from this heading?
That the aorta and the pulmonary artery are interchanged.
Super, very good. So as the name suggests, aorta is now coming from the right heart and pulmonary trunk is coming from the left heart. That's a problem.
Mm.
If this is the problem, means deoxygenated blood, right heart, left heart, deoxygenated blood is going to the entire body. So what do you think would be a peculiar finding in these newborn? When will you see the signs and symptoms?
Earlier
You go to their
cyanosis.
central cyanosis.
Very good. Okay. But when? Early means how early?
Is while the baby starts feeding on and everything, like second, third day of being born.
Okay. So the main, you're close. The main clue, whenever in the question you see there is cyanosis in 24 hours,
Mm.
answer
Okay.
is transposition of great vessels. That is the key thing. Less than 24 hours cyanosis, transposition of great vessels is your answer. Don't look forward. Got it?
Okay.
So this
No,
mostly
that means so cyanosis in less than 24 hours.
not left in entire body within 24 hours.
So what about like a baby who's born like 36 hours later is having cyanosis? So in that case, we exclude transpositions. Could we please just make an example of when about the 24 hours? That's mean like a baby who's having cyanosis in the next 6 hours. Yeah, we
So,
exclude.
I mean, I don't think in Lex there's exact time frame like in 6 hours or 7 hours. But the
Okay.
main key is that in the first day of life, when it is
Okay.
mentioned that the baby developed cyanosis, then definitely transposition of great vessel should be your first thing in mind.
Okay.
Because such a sudden cyanosis just on the first day is nothing but this thing. Because in this thing, if the aorta is from first day only is in the opposite side, means all the deoxygenated blood is circulating in the wrong paths, right?
Okay.
So within 24 hours, earliest in within 24 hours, when you have cyanosis, then this should be your first thing in the mind. Then of course you have to rule out the other options, but you have to keep this in mind.
Okay.
Getting it?
Okay.
So that is the main thing. Another thing, little common only, because in last one, tricuspid atresia, also we saw the second point, that is single S2. Here also we hear a single S2. Why single S2? Because now the aorta is ahead of pulmonary trunk. So because it is over here, the aorta is little bit above the pulmonary trunk, you cannot hear the P2. That is why you have single S2. Pulmonary component becomes very mild because it lies behind the aorta now. Okay, so single S2. But again, I would highly stress on things which are unique. Single S2 is little bit now common. So unique thing is less than 24-hour cyanosis. Clear?
Okay.
Okay.
All right. Then the third topic is complete AV canal defect. What do you know about this thing? What does the name indicate?
That the atrioventricular canals are not differentiated properly, so there is basically no valves at all.
Superb. Very good. So there are no valves. Instead of that, you have one huge hole in the heart.
Yeah.
There is no differentiation, no atrioventricular differentiation. Hence, you have a big hole in the heart, which is called AV canal defect. Okay, can you tell me which condition is this AV canal defect associated with?
Down syndrome.
Super, very high point, Down syndrome. Okay, this is the pulmonary trunk, the aorta. Okay, so number one high yield point is the association with Down syndrome. All right, number two. Now, eventually, when does the signs and symptoms start coming up in this patient? Any rough idea?
No, I don't know. Probably early as well.
Yeah, early, but not within 24 hours. Okay, so the signs and symptoms are more prominent around 6 weeks when the pulmonary vascular resistance falls. I'll explain you how. Now, okay, as you can see, the problem is that there is a common area in between, open area. First, what does a normal heart look like? In a normal heart, you have a proper differentiation of both of these. So, in the pulmonary trunk, only blood that gets the deoxygenated blood coming from the body goes here. The oxygenated blood goes here, right? But now, because they are common, lot of blood, all the blood which is oxygenated also can go back to the lungs. Why 6 weeks? At 6 weeks, when the pulmonary pressure are the lungs. When the pulmonary vascular pressure reduces, all this blood which was coming from the left heart also starts entering the pulmonary trunk, increasing the pulmonary pressure. So this creates pulmonary hypertension in this newborn. Are you guys
So
getting it?
you're saying there's increased amount of blood. There's also deoxygenated blood, and there's also oxygenated blood now going into the pulmonary vessels.
Right. Initially, normal newborn, there is a differentiation like this, where only this deoxygenated blood was going, right? But now, at around 6 weeks, when the pulmonary vascular resistance is falling, means there is no back pressure, right? There is no back pressure as the vascular resistance is low in the lungs. So all this blood from the left heart also starts going in the pulmonary trunk.
Okay.
Right, now your next question should be that why not it is going in the aorta as well?
I think that is high. Pressure is higher than the pulmonary.
Very good, because around at 6 weeks there is a shift of pressures. Pulmonary vascular pressure starts dropping and systemic vascular resistance starts coming up. Right, so majority of the blood starts getting shunted in the pulmonary vessels. So in short, this newborn who has, I'm sorry for the chaos, this newborn who has big AV canal defect, after 6 weeks, around at 6 weeks, there there is pulmonary hypertension, and eventually there is going to be cardiomegaly also. Okay, so pulmonary hypertension is the key point in complete AV canal defect. Because of this pulmonary hypertension, there are going to be increased pulmonary vascular markings. Contrast to the tricuspid atresia where they were decreased. Here they are increased. Makes sense because everything is going towards the lungs, right?
Okay, increase, yes, vascular marking, yes.
Right. So these two are the key points. This is how, just focus on the key points. This is how you will be able to rule out the options as well. Now, if in the question there is cyanosis within 24 hours, loud S2, loud S2 is over here also, single S2. But this is around 6 weeks, you know that. So you will rule this one out. Then, for example, try this question where there in the question it is given increased pulmonary vascular marking. So you can easily rule out tricuspid atresia. The time frame is around 6 weeks. You can easily rule out transposition of great vessels, like that.
Yep.
Just focus on the key things. Got it?
Okay.
All right. So that was that. Then coming
Okay,
to
I have a
everybody.
question.
Yeah.
So this is just the pathology, right? So like, what about like the diagnosis and everything? How do we run those? Like, I mean, like I know ECG is pretty gonna be evident for tricuspid atresia and everything, but
Right.
like for others, like is it all like clinical diagnosis or like how do we pick that up?
Okay. Good question. I'm sorry I missed that. But baseline for everything, what is the first thing that comes to your mind? You tell me.
ECG.
Okay. Other than that,
That, echo.
echo, right?
Echo, yeah.
So all these conditions can be easily seen on an echo. So in cardio, in general, like if I saw, I'm sorry that I forgot to mention it here, but in general, when they ask about diagnostic test, it's only in chest pain we have like various complicated answers, like first to do stress test or ECG, like based on that, chest pain has lot of other options. But other than that, when you have this anatomic defects, the best answer is echo.
Okay.
Okay, and for management point of view, again, they are, to be very honest, I haven't seen much questions where they want to know the management. I think they just expect you to at this point to know what problem it is. But for management, usually it is like, for example, um, it's always surgical. I mean,
Okay, corrected with surgery.
yeah, correct. Usually, because there is no other option, right? If you have this kind of a canal defect, you have to surgically put a septum in between and differentiate the two sides, right? So in all of these, yeah.
I think I once saw a question. I think it was like on transposition of arteries. When they asked, like, I think the best option was like giving like prostaglandin, like to help
Okay.
the like the to
Okay.
keep
So giving
open the.
I don't think that would be the treatment. To be honest, treatment is 100% in transposition, also surgery. But when you mention prostaglandins, good point again, that would have come up in the tetralogy of Fallot thing. But prostaglandins, we are just doing that to bridge the time to the surgery. It's just for the survival. So now, why don't you only tell me when do you give prostaglandins? What's the purpose of prostaglandins?
PDAs to shut them down if there is a connection.
Do you want to shut it down or prostaglandins keep it open?
Is to keep it open.
Open, yes.
Yes. So in transposition of great vessels, because the blood is getting mixed, not mixed actually, the deoxygenated is going to the body, and if there is a PDA in between, you want to keep it open so that the little good blood can also go.
But this is temporary,
I
right?
think
This
the
is not.
question was about like
Yeah.
in the meantime. It was a question that like they want to find like in the meantime, what are they supposed to?
Yeah. So in
Like
the meantime,
the
you can
best
give.
next step. I think those kind of questions like what's your
Right.
best next step?
Right, because you cannot do surgery right away. So,
Yes.
best next step would be to start them on prostaglandins and buy that some time till the surgery.
Okay.
Okay. Right. Yeah. Coming to the easiest topic we all know is the VSD. Okay. Now, one more point that I should mention for all of these. Now, what is a murmur that you hear in VSD? Tell me that first.
Was hollow systolic, I think.
Very good. Holosystolic. Whenever you see holosystolic murmur, what problems come to your mind? VSD. Then in adult, if this is there, then what other murmurs?
Mitral regurg, tricuspid regurg, mitral valve prolapse.
Not mitral
Okay,
valve.
not prolapse. Okay.
Yeah, but definitely the regurg, right? So
Mm-hmm.
perfect. But in child, if you newborn, it is there, it is a VSD. Okay,
Mm-hmm.
so this holosystolic murmur would be given in all of these as well. Not in this one, sorry. In transposition of great vessel, there is ASD and VSD. In tricuspid atresia, there is ASD and VSD. So one of the many points will be a holosystolic murmur. Please don't get distracted by this holosystolic murmur, right?
Okay.
If there is only holosystolic, then you think about VSD. If it is associated with other conditions, then just think that it is because one of the thing is VSD present in this patient. One of the options
Okay.
will be, like, for example, you have this 1, 2, 3, 4 points, and a holosystolic murmur in 5 points are given, including holosystolic. And the options have, the question is, what is the congenital cardiac condition? One of the option is VSD. One of the option is tricuspid atresia. What would you go for?
Of course, atresia.
Exactly, right. So in hurry, in that, sometimes we tend to make those silly mistakes. So don't do that silly mistake. When it's only holosystolic, then think of VSD. Otherwise, it is always associated with something. All right. VSD, the basic things. If it is small, it makes louder noise. If it is big, it is not that rumbling, so the sound is not that strong. Now you tell me, for example, this is a tricky question. For example, a VSD patient, this is a large VSD. Okay, what will be, this is that arrow question, up and down thing. So what will be the pulmonary blood flow or pulmonary pressure, and what will be the left atrial size if a baby has large VSD?
Uh,
Always, whenever there is any cardiac question, make this block in your mind and then imagine and think, if there is a VSD, what will happen?
pulmonary
So do
blood
we
flow
have
will increase.
do we have to think about this question, like also with the having in mind like the 6 week landmark when there's a shift in the pressure?
No.
Does it that okay, it doesn't
But
have to.
VSDs and ASDs are their cyanosis occurs late in life, right? So I mean, it's
Yes. Yeah.
yeah.
VSD can be, it can never be found actually in adult. There can, you and me can have a VSD. Very
Yep.
like smaller one. So yeah.
I think the
But if,
pulmonary blood flow should increase.
okay.
I
And what
might be
about the left
wrong.
size?
Oh, I think even that should increase.
Okay. Why do you think so?
Because if the blood is being shunted from the left ventricle to the right ventricle and then into the pulmonary artery, then the pulmonary blood flow is increased. Hence, the blood comes back eventually into the left atrium. So yeah, the preload
Perfect.
will increase.
Superb. Superb. Everybody else got it? VSD, so the pressure in the when left side of the heart is always higher, as we know. So the blood
Okay.
gets shunted from the left heart to the right heart. From there goes to the pulmonary trunk. Hence, the pulmonary flow increases, and eventually that is all going to come back to the left atrium. So eventually, the left atrial size increases. But this is only only the scenario when there is a large VSD. Okay, this is a question for
Okay.
large VSD. All right.
Mm.
All right. Another question is, first of all, what type of holocystic you already mentioned? Yeah. Okay. Another question is, this is a 8-month-old new baby brought to me, and there is a holosystolic murmur. The parents are asking, what would be the best next step? What is your answer?
So the question again?
If at 8 months a baby is brought with VSD, what is your best next step?
I think let it be because it will settle down itself.
Okay, very good. That's the answer. Now, if a baby is brought at 3 years, what is the best next step?
Then I think you should surgically correct it because, yeah, I guess, I don't know.
Surgery should
Okay.
be answer for 3 years, I would say.
Yeah.
Right. Right. So usually it gets corrected in 2 years, within 2 years normally. So till 2 years you don't do anything. Spontaneous resolution will happen in 2 years. If it persists after that, then you correct it surgically. Okay.
Okay.
All right. Then anything else in VSG
I
that
have a
we
question here.
Yeah.
So since from the diagnosis, like for example, if you're talking about the 3-year-old kid, from the diagnosis until what time we can wait for the corrective surgery? Is there like any window that we have to like or operate the child in, or there's like a time that it's unlimited time till the surgery? You get what I'm trying to ask?
Yeah, I get it. I get it. Even I'm thinking for that one because I haven't seen any questions. So, um, mm-mm. And I don't want to say anything wrong. So I'm not like
Yeah,
I'm
because
not
we always say, "Oh,
sure.
yeah, this is the age, so we are gonna do the surgery." So, is there any like specific
Yeah.
time period that is essential that surgery should be done in that time period?
I think, to be very honest, I think it would be subjective in a way. For example, if it's a very small VSD, then there should
Okay.
not be any hurry to, like correct it. I'm just thinking to, first of all, disclaimer, I am not sure of this answer. I'm just thinking it logically that if it is a very small VSD, then first of all, 75% cases do correct it, just get corrected like that. But if it is not, then there shouldn't be any hurry. But if it is a little larger VSD and it has not at all resolved, then maybe we want to correct it because we don't want it to progress to Eisenmenger syndrome as well.
Mm.
So
Yeah.
maybe there are some kind of cutoffs for the size of the VSD.
Okay. Yeah,
Yeah.
that might be the case though. Then.
Yeah, I think it would majorly depend on the size of the VSD and maybe any presenting symptoms are there or not.
Mm.
Yeah. But I haven't seen any question on that till now, so I'm sorry that I cannot answer it perfectly.
That's okay.
And even for VSD, we're gonna start with echo.
Oh yes, yes. I think best answer for anything is echo.
Okay.
Yeah. Here also it is, as I can see, yeah, echo to evaluate the size and location of exact location of the defect.
Okay.
Right. Okay. Then coming to another topic which we have been doing since step one, which is the tetralogy of Fallot. Okay, tell me what are the four basic problems of TOF?
Left
Is
ventricular obstruction.
Very good. One.
Overriding of aorta.
Very
Yeah.
good. One is right outflow obstruction, so pulmonic stenosis. Second is overriding of aorta. Okay. Then
And PROD, right?
VST?
That's pneumonic. Yeah, VSD.
VSD. Very good.
Uh, There were four, right? Are we done
Yeah.
with four?
Yeah.
Yeah.
Is there
No.
any
One.
hypertrophy in there too?
Yeah,
Yes.
Not
hypertrophy of
sure. Ventricular hypertrophy.
Very good. Right ventricular hypertrophy.
Hypertrophy,
Superb.
yeah.
So 4 points, you guys mentioned it perfectly. Number one, right pulmonary outflow tract obstruction, VSD, overriding aorta, and right ventricular hypertrophy. Hypertrophy is all because there is no blood flow going this way. So this is getting hypertrophied. Another thing, this VSD, usually the shunt is from left to right.
Mm.
But in this one, we will have right to left shunt. Because of this right to left shunt, this right to left shunt is very important. Okay. I'm going to ask you a question on this. Now tell me, how is the patient presentation?
Cyanosis.
Okay.
TED spells.
TED spells, right? So what is TED spells?
When the patient is feeding, that's he starts getting cyanosed completely.
Very good. Cyanosis during feeding or crying or
Crying.
right, whenever in what do you call it? Mm, not stress. I mean, what's stress for a newborn? But yeah, feeding or crying.
Hunger.
I think crying itself is a stress for a newborn.
Stress.
Crying for
Yeah, crying is
because
stress.
he's hungry. So I think that's their
Right.
stress.
Yes, yes. So cyanosis during those kind of situations. Now, Why is there cyanosis during this TED spells? Okay, we'll come to that. But what do you do? What is the management, or what is the best next step in this situation?
I
When they
know
turn whole cyanotic, you need to do something, right? What do you do?
the Valvular maneuver or something. You hold the nose and stuff.
They always try like to increase the pressure, like
The squat, right? Yeah,
squatting
squatting
the
and
baby,
increasing
or
the
There's a
systemic
certain
vascular.
position that should be the child in, I would say.
Right. Right. You all are right. You mentioned the squatting position. So the answer is put them in knee chest position.
Yes.
Right? Why do you
Yeah.
put them in knee chest position?
Increase systemic vascular resistance so that the overriding of the thing
To increase the
gets
venous
better.
return.
Yeah.
Yes, superb. So kinking of the this knee chest position is going to do kinking of the femoral artery, which is further going to increase the systemic vascular resistance. Because of the systemic vascular resistance, now this shunting of the blood from the right to left is stopped, right? Because the pressure in this is increased, right? So the right to left shunting is decreased. That is the purpose.
Okay.
Okay. And that is going to improve the cyanosis. All right. Did I? Yeah, I did that. Okay. Perfect. So that is the main thing about tetralogy of Fallot. What are the next other steps? Like, okay, other than putting them in knee chest position, what else can we do for the management?
There's already a VSD, so I don't know.
Like, you mean surgery or like immediate steps?
No. Yeah, immediate steps, something immediate. Other, if for example, knee chest is not given in the option.
Oxygen.
Very good. You give them inhaled oxygen. What will that do? It will cause inhaled oxygen will cause pulmonary vasodilation. Pulmonary vasodilation will decrease the pulmonary vascular resistance. Hence, the little pressure that can be reduced in this side. That's the purpose. Right? And what else? Oxygen. Yes, that's it. And yeah, this inhaled O2 will also increase the systemic vascular resistance as well. Maybe I think the logic would be to deliver the oxygen to the body parts that needs it, because now the body is in cyanosis, right? So when you give oxygen, the body will try to deliver this oxygen everywhere. So increases the SVR and decreases the PVR. But always the question is on this thing. They want this answer, knee chest position, which increases SVR. Okay?
Yeah.
All right. So that is about this one. All right. So these are actually these were the main complicated ones where you have to think logically. Then there are not logical but the mug up things, which I'll just quickly will run through it. Like, for example, pediatric viral myocarditis. So in that, you just have to mug up which viruses can cause pediatric viral myocarditis. Do you know the viruses?
It's Coxsackie.
Coxsackie.
Very good. Superb.
Yeah.
Coxsackie and Coxsackie is going to be like common even in adults, right?
Parvovirus B19, I would say. No? Okay.
No, not for myocarditis.
Okay.
What else? Adeno? Okay.
Yeah. But usually the question is on Coxsackie only, okay? Then again, like this is one-liner mugging up stuff. Another one-liner mugging up stuff is, where did that go? Kawasaki disease. Okay. Okay. Tell me what are the 5 things of Kawasaki which are very, very high yield?
Strawberry tongue.
Okay.
High fever for more than 5 days.
Very good. Fever for 5 days. Rash.
And
very
rash
good.
like on extremities.
Erythematous polymorphous rash. Very good. Then
Edematous extremities.
Superb. Edematous extremities, strawberry tongue, extremities involvement, edema. Okay. What else?
Mucositis is like same as yeah, strawberry tongue. Yeah.
Strawberry tongue, right?
Yeah.
Then
Are there any heart defects?
that you have to tell me. It's given
No,
in cardio.
it's they,
Myocarditis.
no. I think there's
I think
like it's
PST.
Mm-hmm.
no, it leads to some cardiac defect.
Mm-hmm. Yeah, you're right. There's some complication. It leads to some complication of cardiac. So what are those?
I don't know. I
Uh,
don't remember.
aneurysm of is it aneurysm of the
Arrhythmia, if I'm
Mm-hmm.
not
Mm-hmm.
sure. I don't know.
Good try, everyone. But no, it's coronary artery aneurysm. Magda.
Oh,
yeah
Oh yes,
yeah
yes.
aneurysm? That's a
I
coronary
Oh
just
artery.
my
forgot
goodness.
it.
But I'm sure,
This
see,
one.
these are the things that once you see it in the options, you'll know it right away, right? So
Yeah.
coronary artery aneurysm and myocardial infection, not infection, sorry, is myocardial ischemia, infarction and ischemia. But most commonly asked question is this one, coronary artery aneurysm. Again, but you guys are jumping forward. Here you are missing stuff. Two things very high are missing.
I think there's this conjunctivitis.
Superb.
Um,
Conjunctivitis.
uh, because I always look at it like the only difference which differs from scarlet fever.
Very good. Very good. Then still one more thing.
Lymphadenopathy, is it?
Superb. Cervical lymphadenopathy, right?
Okay.
Okay.
Yeah,
So how would you differentiate Kawasaki from scarlet? Scarlet also has strawberry tongue. What kind of rash is there in
The
scarlet?
rash, sandpaper rash.
Superb. Sandpaper rash. Fever. Anything particular for fever that you know?
I think scarlet, the fever is not that high.
Yes, it does not last this long. After
Yeah.
giving medications for fever, it usually comes down. But here, the fever lasts more than equal to 5 days. And another very high thing, when you see hand or feet, the words hand or feet, blindly go for Kawasaki. Extremity involvement is only seen in Kawasaki and not in scarlet fever. Okay. So, edema, erythema of the extremities, answer is Kawasaki.
Okay.
Clear? All right. So that is one. Oh, then two more conditions were remaining. So this is also an easy one. This is hypertrophic cardiomyopathy
Mm.
in infants. Cardiomyopathy in infants. Which infants would have hypertrophic cardiomyopathy?
I think born
The
from diabetes mother.
Super, very good. Diabetic mothers. Super, very good. All right. So main cause is maternal hyperglycemia. Okay. Because of maternal hyperglycemia, what happens? The fetal glucose also increases. Because of that, insulin also increases in this fetus. And eventually, this increased stuff will increase the glycogen and fat deposition in the septum of the baby's heart and causes left ventricular outflow tract obstruction, just like the adult hypertrophic cardiomyopathy. Okay, these all changes start developing when the fetus is in the mother's womb. So main thing is that once the baby comes out, this condition spontaneously resolves in 1 year. Okay, when the effects of the glucose and everything starts coming down, this condition, that is the high yield point, that it self resolves in one
within
Okay.
a
year.
year.
Okay.
Mm.
So never, no surgery needed. It always comes down. No surgery. Got it?
Yes.
So the presentation is going to be exactly like adults. Now, if there is going to be outflow tract obstruction, what kind of murmur, systolic ejection murmur. Presentation wise, there can be respiratory distress. Now, for example, if this child is having difficulty, then right now you want to do something to help, right? So what can be the treatment option for now?
Prostaglandin.
Why prostaglandins? Why would you like to give that?
Supportive.
I don't know. Sorry. Yeah, I know.
Oh
It's
no,
wrong
don't be
answer.
sorry. You are just giving options, so that's all right. But we don't want to keep the PDA open. There's no logic that I can think about it. Anything else? What do you give in adults if they have hypertrophic cardiomyopathy?
We give metoprolol.
Beta block.
Very good. So here also the answer is actually beta blockers.
Mhm.
Okay. Similar condition, just like adults, we have hypertrophic cardiomyopathy in children. So you want to give beta blockers, just temporary solution, because we know that this is going to come down. Okay. So if they ask what is a treatment, beta blockers. What is the long-term plan for this child? No surgery, self-resolves in 1 year. Both of these are UVOLD. Another UVOLD is maternal diabetes. Clear?
Mhm.
Okay. And last in this one is persistent pulmonary hypertension of newborn. Okay. Tell me a few causes of this persistent. Okay, first of all, I already told you, right? Around 6 weeks, when the pulmonary pressure, vascular resistance should come down, it is not coming down in this newborn. That is the problem. What do you think can? What do you think is causing this? What do you think that is not letting the pulmonary pressure go down?
Surfactant. I don't
Okay, close. So surfactant means what?
know.
Good, good. You're trying.
I mean, I cannot think of something.
Okay, so for example, I would say if there is, this is the diaphragm, right? And if there is a congenital diaphragmatic huge hernia coming out, what is it doing? It is pressing
Contraction.
over this lung,
Mhm.
right? So that it does not let the lung to develop So lung hypoplasia is one of the cause for this persistent pulmonary hypertension. Other, this is like least common one. The most common, when this condition is given to you, when pulmonary hypertension in newborn is given, something that should come up right to your mind is meconium aspiration
Mm.
syndrome. Okay. Meconium aspiration syndrome, lung hypoplasia, or any infection, any pneumonia in the neonate is the cause for persistent pulmonary hypertension. How is the
Mm.
presentation? Respiratory distress, cyanosis, stuff like that. How do you treat this patient? Majority times the question has pulmonary hypertension. This is either given in the question or answer of the question, and the treatment is the question. How would you treat this child?
Do you give us an
Yes,
PDE
yes.
inhibitor or nitrate?
Nitrate. Okay, yeah. So nitric oxide. Nitric oxide has half-life in like seconds. So its effect is very quick. Within seconds, it will cause pulmonary vasodilation. All right. So the answer is nitric oxide. Give them inhaled nitric oxide. That's you will. And of course, like giving them oxygen, ventilation, that is definitely there. But immediate relief, immediate control is by giving inhaled nitric oxide.
Okay.
Another benefit of this inhaled nitric oxide is it acts only on the pulmonary vessels, not in the entire body, right? Half life is with just seconds, so it hardly travels out of the lungs,
Okay.
right? That is why. Clear?
Okay.
Any questions so far?
And are we supposed to run any X-rays or stuff for PPHN?
Good question. No, not
Shouldn't
X-ray.
echo should do good
Yeah,
here too?
yeah, not X-rays. Yeah, I think echo should do good.
Where, what disease is it where you see those bronchograms? Is it this or is it the transient tachypnea? Remember on those chest x-rays you see
That
those?
is. Oh yeah, air bronchograms. That is for that condition, acute respiratory distress syndrome.
Okay, okay,
Neonatal
yeah.
respiratory distress syndrome. Remember where there is surfactant deficiency, um,
I'm
because
mixing
the
these two, yeah, okay. And I understand,
yeah
yeah.
that is that condition. In that you see air bronchograms, right?
Okay.
Okay.
And another question, I'm so sorry.
Oh no.
Transient tachypnea of newborn is different from persistent pulmonary hypertension of newborn, right?
Right. Actually, those questions are there in pulmonology, and they are so high. I cannot stress more on them. Transient tachypnea of newborn, acute neonatal respiratory distress. Then there are 4 5 of them, but yeah, they are all different from
All
this.
different, right?
Yeah, they're
Okay,
all
yeah.
different. Yeah.
Okay.
Transient tachypnea of newborn is where the brain center. I have to check, but the brain center is not 100% developed. That is transient tachypnea. Acute respiratory distress is where the surfactant deficiency is there.
Okay. They all look alike and even sound alike in my head,
Yeah.
but they're different, yeah.
Yeah, they are very different. In my pulmonology sessions, we have like worked a lot on them because again, like they are very confusing. But yeah, I've tried to simplify it there.
Okay.
All right. So lastly here, let me just quickly check if you're missing anything. Yeah, I think the important questions are here. Then if there is something easy that would not be covered, but high yield stuff and difficult to remember is all covered for peds cardio.
Okay.
Do you have like you want questions like on these topics?
You were questions in the sense,
or NBME questions on these topics that I don't know if you that's how you do, like maybe having some questions aside.
right. So how I have like the way I was teaching you, so you can see these questions written that I've like when I write question or answer. So that is something that I've noted from UWorld in my notes. But I don't keep on mentioning it because I don't want to make it easy for you when you solve the questions, right? But these are all UWorld questions only. I don't have the question because my UWorld subscription expired. But these are all UWorld question content only.
Okay.
Yeah, there is nothing extra. This is all just UWorld.
Okay, good.
Okay.
So no, it feels just good. I think I'm going to challenge myself, like on you all, just try to choose all the questions like which are like pediatric, if I can have those one. Pediatric cardiology, then to
So
challenge myself.
you can do like this, that once now that you are done with pediatric cardiology right now with me, right? So tomorrow you can start solving just peds cardio from the UWorld. So whatever topics, like the little topics that would be missing here and there, can also be covered. Plus, you know how to actually, when you implement this, are you able to implement these theory things in the MCQs or not? You will be, I'm 100% sure. But if you solve it, you'll remember this for a longer time. That's the point. You won't forget it. The main thing
Exactly.
is you keep
That's
on
why I ask like
repeating.
if you have questions, because it helps like solving it. It helps solving a question, just like being in front of a certain patient that you saw, and it's stick for long in your mind.
Right. I'm sorry, my UWorld actually expired. Otherwise, I would have done that. But yeah, so the best way is that once you refer to the sessions in those coming like that week, you should solve it from the UWorld as well.
Good.
Okay. Yeah. So that's it for today. Let me first